few quick reminders. If you didn't have a chance to take the AHEC survey yesterday, we'll have that QR code for you. Really helpful if you're able to do that. CEUs, make sure that you sign in and sign out at the end of the day. And I think that's it. A little bit of the housekeeping and everything. Help yourself to coffee. We have some amazing breakouts today. Very excited to share. But first, we're going to have Wendy No from the Dove House out of Indianapolis. Apologies as I'm going to read this. As CEO of Dove Recovery House for Women, the largest transitional housing organization in Marion and Dubois County for women recovering from substance use disorder and trauma. Wendy is responsible for overseeing all operations and programming and growth for the organization, including clinical, fundraising, program development, staff supervision, advocacy, communications, and marketing. Wendy has been advocating for women her entire life with the Julian Center Domestic Violence Network of Indianapolis, Susan G. Komen for The Cure, and now is the leader of the Dove Recovery House for Women. Dove House provides free housing for up to 2 years, peer recovery case management, trauma therapy, IOP, and life skills. Dove House has experienced 60% capacity increase under Wendy's leadership and in numbers served annually, and has increased the budget by 500% in 8 years. Dove House is the home to 40 women each night in Indianapolis and recently opened a secondary location in Dubois County, 2.5 hours south of Indianapolis, and is a 15-bed residential facility. They have also launched a capital campaign to relocate the newly opened Outreach Center, which provides clinical interventions for women on the Dove House waitlist, as well as creates 15 new beds in Indianapolis. Wendy has been awarded the 2006 Indiana Coalition Against Domestic Violence Empowerment Award through education, the 2012 Indiana Center Consortium Cancer Control Champion Award, and the 2017 University of Indianapolis Community Partner Award. Under her leadership, in 2019, Dove House received the Mental Health of America, Indiana's inaugural Recovery Residents of the Year Award. Wow. We are so honored to have Wendy here just to kick off our day and all things substance use and recovery. So please welcome Wendy.
Good morning. All right, you guys ready to go? Sorry, one moment. Okay, that's better. I mean, I like to wing things, but I don't know if I would want to talk about things I'm not an expert on. So, as you heard, my name is Wendy No. I'm the CEO of Dove Recovery House for Women. I'm also a consultant with the Opioid Response Network, which is a national organization funded through SAMHSA administration to provide education, technical resources. But today I'm here to talk to you about substance use disorder, trauma, and women. So I always like to start with an introduction. I think it helps to ensure that we're all on the same page, that we all know how to define substance use disorder. And it's a medical condition that's characterized by harmful substances, so alcohol and different types of drugs. Trauma is an overwhelming experience, such as abuse, neglect, or violence. And then gendered experiences, today we're talking specifically about women, but what we do know is that women oftentimes experience trauma at a higher rate and much differently, thus increasing their risk for substance use disorder. And then the intersectionality is that trauma and substance use disorder are intertwined. And so as a result, it really requires us to have a dual focus approach. And this is why I really like when we have an opportunity to talk about the intermingling of the two diseases, because so often we look at substance use disorder through one lens, and we don't think of substance use disorder as a dual diagnosis, as a co-occurring disease, oftentimes with that trauma approach. And so really, if we want to find solutions and help women overcome substance use disorder, we really have to look at it through that lens of trauma. So why gender-specific recovery? It's not a one-size-fits-all. Women and girls, obviously, are different from men and boys, both in physiologically, cognition, their emotions, social interactions and development, risk and resiliency. And these differences affect the prevention, treatment, and recovery of women and girls. I'm having a hard time seeing, so I'm going to take this. Advocacy and pregnancy, perimenopause, premenopause, menopause, all of the things that us women go through, and I know there are some men in here, so if you're married or have daughters, you can empathize with us on what our bodies go through during our lifetime. And these different periods of life and different hormonal balances can affect how we manage and cope with systems around us. Women with mental health or substance use conditions are oftentimes more stigmatized. They are more marginalized. We tend to look at women as the caregivers in families, which many of us are. And so it's hard to understand or rationalize how could a woman be addicted to something and not take care of her children? How could she choose something other than her kiddos? And so women oftentimes have a harder time accessing treatment. They are more isolated, tend to not talk about substance use disorder as readily as a result of that stigmatization. And women in recovery may also be at a greater risk, as I mentioned, of being blamed or judged. Being female means there's an increased likelihood of violence within their lifetime and trauma at any point throughout a girl's or woman's lifespan. Women oftentimes have a higher incidence of poverty as compared to men. They're often sole caregivers. They often report that stress and negative effect often precipitates their initial use. They develop SUD in less time than men, and they experience different physical effects of substances. You guys have probably heard a lot of these statistics, but the reality is that 1 in 3 women will experience physical violence in their lifetime, and 1 in 5 women are sexually assaulted. So as I look around the room, I imagine that several of us in this room have been victims or know someone that has been a victim of either physical or sexual violence. The different types of trauma that women experience are abuse, neglect, intimate partner violence, sexual assaults. And then there's the mental health component that comes alongside that. Depression, anxiety, PTSD, which all can increase the use of substances as a coping mechanism. We know generational trauma is a key component. This trauma can affect multiple generations of women. There's even some evidence, and you're talking a lot about maternal motherhood. There's a lot of data coming out that shows that when a woman is pregnant, if she is experiencing trauma, secondary trauma can be passed on to that fetus. And 75% of women with substance use disorder have experienced childhood sexual abuse. So this is why it's really important to be talking about this. If you are not asking these questions, then you're only really treating a symptom. We always say is that trauma is the gateway drug. So if we don't identify that trauma, then we're gonna see repeating behavior of substance use. So again, I always say that substance use disorder is secondary to that trauma. Women have very unique trajectories as it relates to substance use disorder. Their needs for treatment are very different. And so again, it's not a one size fits all. At Dove House, we really talk about individualized treatment. Every woman comes in with a different story, within different needs, and we can't treat it black and white, and we certainly can't treat her as we would with men. Their biological factors, so the biological factors and their gender interact in very complex ways, which again create very unique differences in how they respond to treatment. So this comorbidity like PTSD, vast majority of people with substance use disorder have some dual diagnosis of mental health, whether it's bipolar, PTSD, depression, and anxiety. Again, women have reproductive phases, and then again, the caregiving responsibilities and stigma that align with their access to care. So gender differences, women develop SUD much faster than men. It's called the telescoping effect. We've talked about it already, but women face much higher stigma if they have SUD, and they face more severe health consequences from substance use. So a lot more higher mortality and morbidity. And they often, again, have SUD and mental health disorders, so co-occurring disease. It is extremely difficult for women to access care that is specific to women and females. We know that it is often needed for a longer period of time. And yet still in the state of Indiana, we have very limited resources for women with substance use disorder. There's a lot of places for men to go, but for whatever reason, it's still very difficult for women to access treatment. Women with children oftentimes face additional barriers. They may be the primary caregiver. They may not have family support anymore due to their substance use disorder, or may not have anyone that could take care of their children while they access treatment. And for the longevity, the reality is that 28 days is not enough to treat substance use disorder. And they may not have childcare or someone that is able and willing to take care of their kiddos for the extended period of time. They also fear that if they talk about their disease or access treatment, that they will lose their children. And we see this quite often. Women with substance use disorder oftentimes have DCS cases. Their children may be in foster care, and they run the risk of losing custody of their children, which can then create another traumatic experience for them, which only perpetuates their desire to use substances. And then the financial challenges, as we saw, many women are, that are dealing with substance use disorder are living in poverty. And maybe, again, they're sole primary caregiver of their children, the financial ability to financially afford treatment is significantly difficult for them. And then again, the heightened social judgment that prevents women from engaging in treatment. So women often report that stress and the negative effects from relationships are what precipitate first use. 90% of the time, we see that women who begin using substances are introduced to it by a partner or by an abuser. So an adult male that may be abusing them will oftentimes use substances as a mechanism for control and power. Women develop substance use disorders in less time than men, and illicit drug use is less likely to result in emergency department visits or overdose for women. So that sometimes if a woman or a person overdoses and has, hospital care, that may be their linkage to treatment. And so if we're seeing less women interacting in the healthcare system, they may not have knowledge or access and resources to treatment. But we do know that women may be more susceptible to cravings and relapse, and a lot of times we see this based around their cycle, their hormones, the emotional stability. So the struggles are universal, though, for men and women. We know that there is shame and stigma. Now, I always like to just share a little story because I think it helps kind of put things into perspective on how we think about substance use disorder. About a year and a half ago, I was diagnosed with a life-threatening disease. And if left untreated, this disease would ultimately end my life. It would leave my children, my daughters, without their mother, and my husband without his wife. This disease would break the hearts of my family, of my friends. It would certainly leave Dove House in limbo. But fortunately, I was able to access life-saving treatment. For the next 10 years, I will be monitored closely. I had medication that I could access, providers that treated my disease. I had meals provided to me when I was undergoing my treatment, so I never had to worry about going to the grocery store. How was I going to afford this? So my disease was breast cancer. Now, when I share this story with you and share my diagnosis, for some of you, you may have empathy. You may have a personal relationship to it yourself, whether you or someone you know was diagnosed with breast cancer. You probably have compassion, empathy. You're probably not looking at me with judgment. But what if I said that my disease was that I was addicted to heroin? If I said that I needed treatment for heroin, that my disease of addiction to heroin could leave my children without their mother and my husband without his wife? What if I said I needed treatment, but I couldn't afford it? I didn't know how I was going to pay for my meals or my children's meals if I accessed treatment because I was no longer able to work. When I was going through breast cancer treatment, I wasn't able to work, but I had caregivers taking care of me. Women don't have that. So if I stood here and told you that I was dealing with substance use disorder, would you look at me the same way? Some of you probably would because you work in the field. But for others, you would probably look at me a bit more harshly, without understanding, judgment, like how could she? Why would she? Someone like her? And that's the reality that we face. That's the reality that so many women experience. The inability to access treatment, the fear of judgment, even within the healthcare system, so many women face judgment and the inability to access care because of that. And so my challenge to you today is to think about your own stigmas. Think about how you interact with women or men that may have substance use disorder. Think about what do you do and how do you interact that could potentially stop or enable that behavior. So, again, I like to just really challenge you on that shame and stigma because it does exist so often. Women have relationship issues when they are going through substance use disorder. They oftentimes have fear of losing their children, their partner. They may need a partner's permission to obtain treatment. We see it often that, again, like childhood, that partner may be the one that is providing them with the drugs or the alcohol as a way to keeping control over them. Treatment issues, lack of services for women exist. Not understanding women's treatment. We know that there are treatment programs that provide additional trauma when they go through the program. And programs that don't have trauma-informed care can harm that person. We have long waiting lists, lack of childcare services, there's systemic issues, lack of financial resources, lack of sober housing, and then poorly coordinated services. All of these barriers that impact a woman's access to treatment. Women with substance use disorder often have histories that include 3 elements: substance use since early adolescent, which thus creates developmental delays. The average age that a person starts using drugs or alcohol is the age their brain stops maturing. Average age of first drug use at Dove House is 13 years old. So what we always say is that we have a house of 13 and 14-year-olds. So conflict resolution, how to communicate, just those life skills, they don't exist. And so it's our job to help provide those skills to help them navigate throughout life. And so these developmental delays can be caused by damaging relationships, multiple traumas, which oftentimes include physical and sexual abuse. At Dove House, nearly 100% of our women experience physical or sexual abuse as an adult, and 90% of them experience childhood sexual abuse. And this is comparable to the national average. 80% of the women that seek treatment, so these are national numbers, report a history of sexual assault, physical assault, or both. And unfortunately, those are only the people that are accessing treatment and self-reporting. The majority of women who suffer from substance use disorder oftentimes suffer from PTSD stemming from childhood abuse and then continue into adulthood. Women often use substances to numb. It is why they may start using drugs or alcohol at a very young age to numb those negative feelings that they're having, the abuse that they've experienced. And then substance use worsens with mental health, and that leads then to more trauma. And then unaddressed substance use disorder or unaddressed trauma within substance use disorder treatment can oftentimes lead to relapse, which we've mentioned. And then trauma from mothers affect these future generations. Studies of alcoholic women indicate that they are more likely to report that they've had childhood physical and emotional abuse than women who have not. In fact, women who have been abused are 15 times more likely to use substances. And then relative to the childhood abuse that they've suffered, the National Center of Addiction and Substance Use have found that 75% of women who are being treated for substance use disorder have oftentimes been sexually abused as well. And according to the majority of domestic violence program directors, about 51%, a woman's use of alcohol can be a barrier to being able to have, can be that relationship why she is in a negative or unhealthy relationship. Many times, women that are in domestic violence relationships also suffer from substance use disorder and do it as a coping mechanism. And that batterer will often, again, serve as the woman's financial support. He's been controlling her with finances. He may be her enabler and often directly supplying her with drugs and alcohol. So women that have experienced trauma are 2 times higher risk of lifetime stalking and contact sexual violence. They are much higher likelihood of being injured by an abuser. They are more likely to experience long-term negative impact from violence or stalking, and they have a higher risk for types of traumas more likely to result in PTSD, regardless of their sex or gender. And then this is, I always like to show this chart because it shows what services are being offered within substance use disorder treatment facilities. 96% of them are receiving some form of case management. 75% of them receive mental health. 46% transportation assistance. 38% domestic violence. Only 6% offer childcare. And then 3% residential care for a woman's child. So you can see the vast discrepancy between what's being offered. So how do people access treatment? What are the modalities? What's the pathway in which this happens? So again, we see the symptoms of substance use disorder, and then we see the social impact, relationships, the parental responsibilities, psychological, which is trauma and mental health, and then biologicals, which is sexual and reproductive health. And we've talked a lot about this, but the trauma, the mental health component, psychiatric or psychiatry, counseling, which then also can help a woman feel safe, welcoming when it's a women's only program. Combined men and women treatment program just doesn't work. Lots of times we'll see women become pregnant and in unhealthy relationships with someone that they meet while they're in the program. We at Dove House tell women that they are not allowed to go to co-ed meetings, 12-step meetings, until they have been in our program for somewhere between 4 and 5 months, because we were seeing a lot of times that they were getting all dressed up and looking nice when all day they've been in their pajamas and casuals, but then they're going to go to a meeting and there's men there and they get all dressed up. It's missing the purpose. And so we block and stop until they're at a certain level at our program, because we don't want any more Dove babies. We see that, again, the sexual health, and then just really having gender responsive care, understanding that women respond differently in different periods of their life to treatment and to why they may use substances. And again, I'm kind of hitting it over the head and saying this multiple times, but we must identify the trauma and treat it as a co-occurring disease. Because again, if we don't understand what the root cause is, we're going to see repeating behaviors. And I think that's why, for so long, we haven't been able to effectively treat substance use disorder, because we were looking at it as a primary condition when really, truly, it's an outcome of something else. Because of co-occurring disorders, women in SUD treatment will benefit from an environment that is feeling safe and supportive. For some women, it may mean that being in a small, tight room without a window can be traumatic. It may not feel like a safe place to them. And so putting them in a room where there's windows, where there's more open air, perhaps where there's other people around them, may make them feel safer. So coming from a trauma lens and understanding that approach will help that woman be more successful in her journey of treatment. The criminalization of SUD and increased policing on women and police violence can discourage women to accessing treatment. Again, same reason why women don't want to self-report that they may be suffering from this disease is because they're fearful of losing their children. And, when a woman gets arrested for drugs or alcohol and she's automatically hit with a felony charge, imagine how difficult that is then for that woman to get a well-paying job that will allow her to take care of her children, to find safe, affordable housing, maybe to get her license reinstated, are all barriers to becoming sober and self-sufficient. Harm reduction and other low-barrier treatment programs can be male-dominated, thus limiting women's access to care. So it's important to offer some of these interventions for women when they're going through treatment, seeking safety groups, really talking about that trauma lens, understanding trauma, where did it come from. Peer support groups that are designed specifically for women, led by other women who have navigated this journey. Holistic care, so including housing, childcare, transportation, vocational training, trauma therapy, EMDR specifically, CBT, DBT, women-only 12-step meetings, motivational interviewing, integrated treatment options and plans that address both their co-occurring disease like mental health and substance use disorder. And then support services, as I mentioned, which is transportation, employment, assistance, childcare, child visitation, are all key indicators of a successful program. Again, remember that if we are operating with people with a capacity of 13 years old or 14 years old, we can't expect them to be operating at their age of 45 if that's how old they are. We really have to offer services that are completely comprehensive and holistic. So trauma-informed care approaches and recognizes the role in how trauma shapes behaviors. Having a holistic person-centered care would address the physical, mental, and emotional and social needs of that person. Gender-specific services, so services, again, tailored specifically for women, including reproductive health and parenting support. Community-based support, partnering with local organizations for wraparound services. So even though you may not have therapists on staff, working with those in the community that can provide that and having an MOU with them is critically important. And then peer support networks, offering that emotional support so that women know and men know that they are not alone in this journey, that there are people that have walked this journey, that they understand, they know what success looks like, and can really just be that support service, that accountability partner, and helps navigate them through treatment. This peer support is that shared experience. Again, that feeling of isolation is removed because they know they're not alone in this disease. It helps build trust. It bridges gaps in care. It's a model of hope, resiliency, and inspiration. It reduces isolation. It leads they lead peer support groups, relapse prevention. They have an understanding and a sensitivity to trauma. And it's really empowering. So the most important thing, again, is to really understand how trauma goes hand in hand with substance use disorder. The importance of collaboration, healthcare providers, direct care providers, community organizations, policymakers, we all have to work together. And we have to talk about this. We have to come from a different lens, stop looking at this with a lens of stigma, but rather a lens of collaboration and partnership. How do we treat people? How do we treat them holistically? How do we remove barriers? And how do we ensure they can get through the entire continuum of care, whatever that continuum of care looks like? And then spreading the idea that hope is and recovery is possible. It is possible with the right support, which can lead women to having very fulfilling lives. And then I always like to end on this. You know, I have worked in the field of substance use disorder now for 10 years, but I learned so much listening to this podcast called The 13th Step. It is based out of New Hampshire, and it was through NPR. And it talked about a male that was in recovery himself and started a treatment program for men and women, and the sexual violence that came alongside that. How women were re-injured, abused through treatment modalities, and really lost trust in the treatment services. And oftentimes, it happens. It happens more than we believe. It happens a lot in Indiana, especially when we see for-profit institutions coming in just to make money off clients. And so check it out. It's about, I think, 8 episodes. It's a fascinating listen. And if you haven't read the book or listened to the book, The Many Stories or The Many Lives of Mama Love, it is incredible. Again, another just life-changing book for me. Working in this field, having family members with this disease, again, opened my eyes, and especially really kind of highlights the different needs that a woman has when she's going through treatment, the different barriers she has. This is a woman that was in California, grew up in an affluent neighborhood, lived in an affluent neighborhood, even the issues of transportation, the incarceration, and then her survivorship over substance use disorder. It is an incredible read. And she's done a TED Talk, she's been on Oprah, she's an amazing speaker. So check those 2 things out. And then I'd be remiss if I didn't talk to you a little bit about Dove Recovery House for Women. As you heard, we are located in Indianapolis and Du Bois County. We're getting ready to open our 3rd location about a year from now in Columbus, Indiana. We just broke ground. And we provide comprehensive wraparound treatment services for women at no charge. So we never expect payment or rent to access our services. So we remove that barrier off the top to ensure that they can access free treatment, because we know that's the #1 barrier to care. We ask for a 90-day stay, and they can stay with us for 2 years. And while they're there with us, they're getting peer recovery support services, life skills, individual and group therapy, IOP, and the average length of stay is between 6 and 7 months. And when they complete our program, they can move into a program called Steps to Success, which is a phase 2 initiative of our program where we provide 8 months of rental support. So for 4 months, up to 50%, the following 4 months, up to 25%. And while they're going through that program, they're continuously meeting with their peer recovery coach, they're getting individual therapy, and they're coming back for relapse prevention. And we have seen great success. About 87% of our women that go into our program maintain sobriety, maintain employment, housing stability, and are not reincarcerated. So if you want to learn more about Dove Recovery House, I'd welcome you to check out our website, doverecoveryhouse.org. I also brought some flyers that I can leave somewhere. And certainly happy to answer any questions that you may have about Dove House or about the work that we do. We also provide a lot of technical assistance, so happy to, if you're in this journey of trying to figure out how to help women, certainly happy to answer any questions. We've seen it all. When Dove House started, I had a staff of 6 and an annual operating budget of $250,000, and today we're just shy of a $3 million budget and 36 staff members and 55 women a night, soon to be, I think, like 80, because we're expanding in Indy and in Columbus. So we've seen it all. And this is my contact information. Should you have any questions and want to reach out to me. My email address, my LinkedIn, and my phone number. So any questions for me? I think we have just a couple of minutes. Oh, yes. Not at Dove House. We do provide DCS site supervision there. The kiddos can spend the night. They can have sleepovers or visitation. Unfortunately, we're not equipped to have children live with us. It's something I'm trying to figure out. I have ideas and visions of how I'd like to help women with children, but we're not quite there yet, but hopefully soon. Yeah, absolutely. So it just means that they are willing to live their life absence-free from drugs and alcohol. Now, we do accept women on MAT, all forms of MAT, but it just means that they are no longer going to be using drugs or alcohol as coping mechanisms. Did I see somebody else with their hand up? Yes, ma'am. We do. Yep, we sure do. Yeah, so our rule of thumb is they can stay with us for 90 days, but a lot of times we'll move them into our Steps to Success program so they can continue to get that treatment. Yes, ma'am. We are not a medical provider, but we have partnerships with physicians that will provide that. And the great thing is that, a lot of times MAT providers will want them to have behavioral health care at their clinic. And because we really want to be holistic and make sure that all of our services are under one roof, we have MOUs and partnerships where we'll join for staff meetings, but they allow our clients to get behavioral health care at Dove House. Oh, yeah. Nearly 100% of our women have some sort of interaction with criminal justice. A good amount of them have felony charges, maybe on house arrest, maybe on probation, have left the prison system. We have contract beds with the Marion County Drug Treatment Court. So they have 6 beds, Hancock County Probation Department. And then we're working the Du Bois County, it's through Du Bois County, the city of Jasper. We have several beds down there for them, and that's through drug court, reentry, and probation. We have partnerships with DCS, and then we're working on creating a partnership when we expand in Indy with the Marion County Community Corrections, which oversees all electronic monitoring. And we provide compliance reports to any probation or anyone if they're on monitoring. We do drug screens on site so we can track what their screens are, what groups and sessions they're attending, and we send compliance reports every single month. And we've developed a great partnership with criminal justice. For our partnerships with our contract beds, they can bypass our wait list usually because we have an agreement with them, but our wait list is anywhere between 3 and 4 months, unfortunately, right now. But we are expanding in Indy by 15 beds, so I'm hoping that reduces it a little bit. It's one of the reasons why we started our Steps to Success program was to move women out of our program a little bit quicker, but stay under the umbrella of Dove House. We don't do detox, but we don't expect a negative screen. So if they need to detox, we're gonna work with a partner. A lot of times, because of our wait list, we're gonna send them to a 28-day stay somewhere, and then get them to Dove House immediately following that 28-day, but they don't have to have a negative screen to come into our program. Yep. There's different programs that we work with. If one of the things we try to do as soon as a woman interacts with our outreach department is get her on Medicaid so that she can get into a detox program that accepts Medicaid. Great questions. Yes, sir. It just depends. Like if they're coming from Fort Wayne, probably not. If they're in Indianapolis, we may send an Uber. Yeah. Any other questions? Well, thank you very much for your time. I'll leave my contact information, and I hope you all have a great conference. Thank you.
Okay, everybody, thank you guys so much, and thank you, Wendy. Prior to hearing Wendy speak, had anybody been familiar with Dove House in Indianapolis? Okay, cool, a few people. Now we all know, so probably expect a few phone calls and emails. So our next speaker, I think Alicia, there she is, all right. So we have Alicia Wells. So if you participated in our seminar in September, you may have heard Alicia speak, and she is such a game changer in our community regarding recovery and second chances and supporting women and families. We're so excited to have her. She's the founder of Wells Inspiration. And with her today, we have a special guest. His name is Brandon. I tried to do it in my head. Dr. Z. I tried. But thank you so much. So we are so excited to have Alicia and Dr. Z here. And enjoy.
Awesome. Okay. Thanks so much. We're going to share the mic. We were really wanting to do more of a fireside chat to be able to talk about community, especially women dealing with substance use disorder. I am a woman walking my own recovery journey, and I always like to say it's never linear. There's no such thing as perfection. You can be walking along, think you're doing everything right, and all of a sudden, the next thing you know, right, you hit a pothole. And that's exactly what happened to me. I've been in the recovery realm for about 12 years. I've been doing this kind of work since 2018, but it was about a year ago that life, right, smacks you dead in the face. And I was staring at a very tough family situation. I was looking in the mirror and did not like who I'd become, and realized that I needed to be back in the game, working a program, getting honest with myself and everyone else. And Dr. Z is somebody very well respected in the community. He's also my provider. And what we're going to talk about today comes from a place of experience, but also comes from a place of advocacy. And when I went to Dr. Z, it was very hard to open up because he and I have stood on stages before and say, I'm at a low point. And he looked right at me and he said, okay, you're exactly where you should be. And I realized in that moment, as I've stood on stages around the state talking about advocacy, I was full of guilt and shame and carrying the stigma inside myself. It was a wake-up call. And from that moment on, we have been working, and he invited me into a women's recovery group inside his practice. And it's been life-changing. And so we are going to talk about the group, the importance of the group from my perspective, as well as the provider's perspective, and how you can host one too. So Dr. Z, will you tell us a little bit about yourself? Because you've got a lot of letters next to your name.
So I'm a family medicine and addiction medicine physician in a small private practice in South Bend, Indiana. I've been doing addiction medicine for 10 to 15 years. I don't honestly remember. The addiction side of things, we mostly treat pregnant women and mothers, mostly with opiate use disorder, but we certainly have men in our practice, as well as other substances and some behavioral addictions as well. We formed the women's group. We've iterated it a couple of different ways over the years. COVID kind of interrupted one attempt that we had before, but the one that we have now has been going on for probably a year and a half. It's a closed group of women that I've chosen from my practice that are stable in recovery. That they're not all, certainly, there's no mandatory amount of time that they have to be in recovery, but I would just say stable. We don't want to introduce a new person to a group and then have them fall back out again right away, because there's a lot of trust that has to be kind of built up before some of the discussions that happen in the group. And really the thing that went into it, I felt like I was having very similar conversations with women repeatedly through the day. And I was like, well, gosh, if we could get everyone together and have this conversation over an hour all together, that will be much more efficient than me having it for 15 minutes, 7 times a day. So that's really where it came from my perspective. And I think it's been a really good thing for them to build that support out. We've even taken the show on the road a few times and brought the group to talk to a couple conferences as well, which we'll talk about later. So,
this group, knowing, just to share a little bit about my story, I was a pregnant mom on medication-assisted therapy back in 2013, 2012 to 2013, and there was tons of stigma, not a lot of knowledge. And my son was born, and shortly after, I relapsed with really no support at that time, and served in my time through the Indiana Department of Corrections. And I left when he was 4 months old and did not come home until he was almost 4. So missing out on all of that, there's trauma that was part of that, and even feeling like you don't fit in some other groups. You don't feel like you fit in anywhere. And so many times you feel as if you don't belong anywhere. And you put on these masks, I know I did, to fit in different places, to be seen and to be heard. And when you take those masks off and you start embracing who you are and the journey, the real journey, and you sit in rooms, I can tell you that the last year of my life has been the most refreshing, the hardest, and yet the journey has almost been full circle. So in this room with these women, we talk about how hard it is to be a mom, how hard it is to not always know exactly what to do, to have people judging, are you doing the right thing? Are you going to relapse again? We have a lot of that. When we're able to come into a safe place, sometimes it gets a little crazy and Dr. Z just shakes his head. And then other times he brings different solutions to the table, such as holistic and alternative pain management techniques. One of the best things that we got to do was a mouth swab, where we did a gene site testing for our medications to see, and it turns out I was on all the wrong medicines. And it's been life-changing for me. And so the women wanted to be here today. We gave them the opportunity. Jennifer opened up for them. But because they're moms, and one is even from Fort Wayne, working at a local hospital, and she drives to South Bend once a month for this group, and they couldn't be here. But on the stages that we've been a part of was a nurses event where we shared our personal experiences about giving birth, either on MAT or with substances in our systems, some of the girls. It was a really cool moment where we were sharing, and I remember very vividly, I have a picture of holding my newborn baby in this moment, and the nurse was scowling as she was pushing me out. That was my experience of giving birth on MAT. As I'm standing there and sharing, and also then saying, however, there was this one nurse that stayed way beyond her time and took pictures and tried to make it right. She was in the audience that day, and we were able to publicly hug, and I was able to thank her in front of her peers for the work that she did. The women on this, we were all crying. It was a blubbery mess, you could say. But in that moment, it was where our group was able to unite, and the power in that. And we only see each other once a month. And so, Dr. Z, from your practices standpoint, when you were designing this group, and if we have other providers or maybe entrepreneurs that host groups in the area, maybe this would be a group they would consider, what advice would you tell them, or how would they begin to create a mom's group within their realm?
Maybe I'll start just a little with the way we structure the group. It's on a fixed day. It's always the fourth Wednesday. The group is from 3:30 to 4:30, so it's kind of the end of my day, so that if it runs over, it runs over. I don't have to worry about getting back to another patient or something like that. And we have about a 30-minute window where the women start to arrive around 3 o'clock. Some of them, probably half of the group, chooses to have an individual appointment with me, separated by a couple weeks each month, and about half of the group only has group as their appointment with me each month. So there's things like, vital signs. Several of the women are on injectable medication, so they can get their dose of medicine during that time while the nurses are kind of like getting them set up. I'm wrapping up with patients. I'm always running behind by that point of the day. So usually by about 3:30, they're all checked in and ready and waiting in a room, and I can run over, and then we kind of have our meeting. We don't have a hard curriculum. We usually kind of base what do you want to talk about next month based on what we've talked about last month. We'll bring in some guest speakers, like we've brought in a dietitian to talk about healthy eating on a budget. We've brought in a woman in recovery that's a physical trainer that did some just body weight exercise with them.
Acupuncture.
That was acupuncture weird. On them. Yeah, so we just kind of flow based on what the group needs at that next meeting. I would say, for those of you considering something like this, like just look at your practices and say, hey, where are the holes? Where are things in our community not meeting the needs of the patients? So as Alicia alluded to earlier, like being a mom is very difficult. Being a mom in the context of recovery is even more so. How do you have these conversations of like, I'm worried about how I'm going to make choices and am I going to be a good mom? If I talk to my family, they may kind of freak out that I'm on relapse watch, where I'm really not. I just have questions. I can't really talk about these things with the soccer mom group because they don't have shared experiences with me. So that was really the conversations I felt like I was having a lot. And I was like, well, the real experts in the room are them. I'm there to moderate. I'm not an expert in these things at all. So let's get them together and let them teach each other, and I'll be along for the ride and learn and offer some advice along the way and stuff too. So,
and we are drug screened for accountability, which I absolutely love. I think that has been many times when you're walking into some different meetings, you don't know if everyone is, in recovery like they say they are. And so we have random drug screens. We are expected to be walking in that. And it's been a place for me in the last year that it's just good. Even now, 12 years in, right? Because things happen. And that's the part that sometimes I think we forget, that there's no such thing as perfection. And we can't hold people to a standard of perfection because that's not real. And things are going to happen. And if we keep walking this line that we only have this limited space that we're going to talk about, that we're only going to say that this is the way it's going to be, this is what we're going to do, we sometimes are keeping people sick on the sidelines because they're afraid to say they're struggling. There's moms that are dealing with postpartum that are afraid to say, I hate this. The baby cries all the time, right? They don't want to say that out loud because all of a sudden there's someone going, well, did you do it this way? Are you doing it my way? We've learned in this group that many of us have different ways to approaching recovery, but we're all in recovery. And we're supporting each other. And what Kara's way, right, might be different than Alicia's way, but she's thriving. And my respect for that has opened my eyes to there are multiple pathways to dealing with recovery. There's multiple pathways in dealing with postpartum issues and motherhood, and it's all about that support piece. The more that we continue to put people in boxes and carry that guilt and shame, more people are going to continue to stay on the outside of the group for the fear of what they just might say that raises an eyebrow. I was that woman. I was scared because I didn't know if it would be accepted or appropriate. Watching our women become advocates for themselves within their families, at their jobs, and that's where I'm going to go. Dr. Z, sometimes in your practice, or maybe with our guests out here, they come across somebody that they know are struggling, but they don't know how to begin that conversation. Some people, I know in this room, are very good at that conversation, and they're, are you okay? But some people, they're just afraid to take that step. What words of wisdom could you share that would be a good way to start that conversation with someone?
That wasn't on your script for today. That's a hard question. I mean, I think a lot of that will be born out of your relationship with people. That conversation will not likely happen to strangers. I guess for some of you in your professions, it probably will actually. But I think just coming to people with just a true, I'm here to help you. I understand, and maybe this isn't a conversation you want to have right now, but I'm here. My shift lasts 12 hours. I'll be back tomorrow. Just, whenever you're ready, I'm here to talk to you. Like, I think our role is we can't make people get better. We can't force them to go to treatment. But we can remove as many obstacles as we can so that when that moment happens and they are wanting it, that they can access the care that they need as fast as possible. So, and it's hard. We have a wait list too, and it's difficult because it is just kind of the way that practices are. If you call my office and you say you have a pregnant lady that needs treatment, I will probably see them today or tomorrow.
He always sees them tomorrow. I can tell you
because that's what we do. But it's not always possible. So I would just say just being as open as possible and in a caring way, and just it usually doesn't take a lot of talking on your part. It really takes more just kind of listening and quiet, which is an easy job for me because I'm a quiet person. But yeah, I think that would be my recommendation, I guess. So
I love that. So I'm going to ask a question, and by hands only, who in here considers themselves a recovery advocate? Raise your hand. That's a good number. What if I told you every single one of you have the ability to be a recovery advocate or an advocate in general? It's as simple as being able to say, I have a number for you to call. Being able to be a connecting piece to say, I know of a resource. I know somebody that you can call. And what I like to say is, we just heard from Wendy about the innovative approaches. And like I said, I stood on this stage last year and I said the same thing. Fort Wayne has some of the best innovative approaches in support. And so knowing who your resources are that you can call is going to be your empowering piece so that you can be that advocate. You don't always have to have the answers. You don't always have to know exactly what to do to be able to help somebody. You just have to be willing to connect them and be supportive in that process. So, with that being said, now I'm going to ask again, who in here believes that they could be a recovery advocate? That's right. You all have that capability. So I encourage you to get to know the resources in your area. I encourage you to know the family support resources, because many times that's what we see, that there's a gap, and you guys have some excellent ones. One being here today. And she's a phone call away, and she will connect you. And so when we celebrate the resources, when we know what is happening, that's where that empowerment piece kind of comes in. And when we look at our women's group, when we look at the connection that's happening, and we look at from the provider's perspective that it makes sense, even though it takes an hour out of a month, what we've seen in our group in the last year is we have women that are now standing on their own 2 feet, walking solidly their path. We see more people coming into the group. Our group has recently grown. And you see people being intentional about what they're doing, and when we come in, we're ready to go. And so in this full circle moment of our community, our group, Dr. Z has been able to empower us, and we're hopeful that we can empower you to consider, wherever you are, creating a women's group, because it is so necessary. Because many times they don't want to walk into, we hear that quite a bit, that going to co-ed groups can be a trigger. So that was our spiel today about community and our connection piece. We were very excited to be here, and we wanted to make sure that we left enough time for questions for Dr. Z, especially from the practice side of things, if you have any questions on how you can start a group. And yeah, thank you. Are there any questions, though, for Dr. Z or?
Oh, gosh. Well, I would say I'm going to answer that in 2 ways. One, just a positive test. I strongly believe that if a person has an abnormal urine drug test, that it just means they need more care from us. I'm not a fan of the, you can't keep coming here kind of method of having abnormal drug screens. I think on a group day, I would have to take that as what does this person look like in front of me right now? Do they have an abnormal drug test, but they look like they're able to participate in group without triggering everybody? That's how I'd play that out. If it looked like they were unable to do that, then I would ask them to just return, make an appointment, return for the next group. I think that's how I would handle that. Hasn't happened yet, actually, but yeah, just making sure that they have their appointment with me set up for further management as well.
I think to dive in that too, we have a group text with our group, with our moms group, with our women's group that he's actually on. And so we have that connection piece of somebody struggling. If there is something that's happening, we are, as a group, walking with that person in that moment. And so that group text thread, although the group meets once a month, our group text thread, while people are checking things at lunch, there's been a lot of encouragement through that.
Yes. Yeah, I think actually everyone in the group is currently on something. It's not a mandatory thing. You could be in group without being on MAT as well, but you can be as well.
Is the group free for participants to attend, or do you bill insurance, or how does that work?
I bill insurance for it. Yeah, so nothing's collected up front, but I do. Are there physicians in the room. I guess I don't know if exactly. Yeah, so you can bill group visits through your practice. I just do it that way.
And I also host a women's group inside of the St. Joseph County Jail that is completely free. So we're able to go inside there as well.
I'm assuming that all of the women in this group are patients of yours, so I'm wondering if you think that there's any barriers to them speaking openly about their experiences with substance use since you also treat them.
There are, right now, everybody in the group is my patient. We've talked about having it open to outside people. That kind of vetting process is a little bit different there because, like I said, we want to make sure people are stable in recovery. One of my partners, my practice has 5 providers, so one of my partners just referred a patient to that I don't know well. I'd like to think that it won't cause barriers to discussing things because of our relationship. I think my patients understand they can come in and tell me that things aren't going well, that I want to hear that just as much as I want to hear that it is going well. If you're struggling, the place to be is my practice in an appointment so that we can work on it. So I don't believe it is a significant impact. You can probably answer that better. But
Yeah, I would say from the group's perspective, we're very open, sometimes a little too open. That's when he rolls his eyes and laughs at us. But you will see that we are very open. We feel very supported because there are multiple pathways taking place. And so that's where it has allowed us to have different perspectives that we've been able to give. But I would say even in our group thread, there's very honest conversation.
I'd say again, my practice is not one of like, if you're not acing recovery, that you're not my patient anymore. So yeah, you can still be in treatment in my practice and not and have a drug test that's abnormal or something like that. It's okay. We just have work to do. So.
Any other questions?
Mine is not necessarily group related. Recently we had a mom deliver, and she was from the Elkhart area and was actively using and just wanted to be able to have extra support and follow up. I was able to give her your contact information, your name. Is there another process that we could use to get them like on your list of patients to see or to follow up with?
No, I mean, where do you work?
I work at Parkview.
Parkview. Yeah, I mean, you guys, like your entity could contact my office. You could work through Alicia. She's kind of a peer coach coordinator person in our neighborhood as well. Any of that would work. The patient could call directly. Yeah.
Again, he is usually pretty available by text, that we're able to get people in pretty quickly. And so reaching out. And then we also now have a new peer in the group who actually works on labor and delivery at one of our local hospitals. So we have now started to be actually in the jails, on the floor, providing support and also advocacy for what multiple pathways look like. Any other questions?
Any advice on finding a champion like you in our community?
There are so many champions in this room. If you turn around, there's 2. If there's one right there behind you. There are so many advocates and champions from the Fort Wayne community right in this room. So you have Sierra behind you. You've got Jen Hope right to your others. I mean, there are amazing community champions. And 9 times out of 10, we're working together because collaboration is key. And so by calling one of us, if you need somebody out this way, we're going to be texting and finding you that connection. So it takes all of us to be a champion, right? And some days, I'm not always the best one to call, maybe, so finding your group and saying, hey, I need such and such, and know that we're going to be able to connect. So I'd be happy to give you my card. Again, you have wonderful champions right behind you as well, and we'd be able to help in any way possible.
And I'm from another community, so
Oh, which community?
let's see here.
Oh, yes, we can definitely connect you to, we've got We definitely have some. So I'll make sure if you turn around and you'll see a blonde, she's going to be speaking, her name's Sierra. She can connect you with one from her team in the Muncie area, as well as if you want, I'll give you my card, and we've got a couple women down there as well. And the Summer of Recovery tour is getting ready to happen across the state. There's 5 cities. That was my baby that I was a part of. This summer I will not, because I am taking an actual baby as of tomorrow. So my new motherhood journey begins tomorrow. So, yeah. So there's 5 cities, and you'll find all your recovery champions there. Summerofrecovery.com. Those still come to my email, but I'll connect you. Any other questions? Wonderful. Thanks, Jen, so much for an amazing conference. You are killing it, and we are so glad to be here. Thank you.
All right, thank you guys. So we are going to get you moving. We're going to go into our breakouts. Well, I guess not everybody if you're staying here. So in the auditorium, we have Megan Ryan from Benchmark Human Services and also Jody Cole from Meridian Health Services. And in the gymnasium, we have Jackie Franks from the Indiana Alliance on Perinatal Substance Exposure and Carrie Michael from the Pregnancy Promise Program. So we don't have a vendor village in between, so you guys can stay here if you're going to stay here or go to the gymnasium, and we'll get started again. Thank you guys. right, so we have Megan here from Benchmark Human Services. The presentation is called The Silent Struggle, Addressing Mental Health in Motherhood. So we are so excited to have Megan here. We also have Chad from Enact Mobile Crisis and to do their presentation, so take it away.
Thank you. Yeah, you nailed it. Thank you. Good morning. Everyone, I think most of you have a handout. I tried to make enough copies, so I'm sorry if you don't have one, but I can always email it to you. I want you to be able to use it as a reference later on, and then you don't have to wait for me to email it to you because you already have it. And then you should just have like a little goodie bag just celebrating Mental Health Awareness Month and also getting ready to celebrate the lovely holiday that we have on Sunday. So thank you for being here. My name's Megan Ryan. I am a licensed mental health counselor. I work for Benchmark Human Services, and I'm the Family Preservation Program Director. And I just want to share a few things with you today. So I'm going to start with some quotes. These quotes are directly from my friends. I want to be at work. I've pushed so hard for my career, but I also want to be with my kids and watch them grow, especially when they are sick. I need to be at work. I want to be at work, but I so desperately want to be there to comfort them. I'm dedicated to my job, but if I say I miss my kids or want to go home early or need to take a call, in my male-led profession, it's misunderstood as not being dedicated or serious. I struggled with trusting others to respect and follow the decisions we made. We often heard, well, when you were a baby, or we did it this way. We made different choices for our kids that they don't always understand or agree with, but we think it is best, and it causes tension sometimes. I constantly worry that I'm not raising him to grow into a kind, respectful person who makes a positive impact on the world. Finding yourself again, becoming a mom shifts who you are, then you miss who you were, there we go, while also wanting to be that person again. And being a special needs parent is also very isolating. My kids don't necessarily play with the other kids, so it's not like play dates are a thing for me. Finding other families of kids with autism has helped, but even with the same diagnosis, our kids are still so different. And then lastly, I would say the mental load that we carry constantly in our minds about remembering to schedule appointments, making sure this is done and that is done. So bravely, just a show of your hands, does anybody relate, whether you are mom, dad, just a caregiver in general, to any of those statements? So today we're going to talk through the silent struggle addressing mental health in motherhood. A few things that I hope that you can take away from today is I would like for you to understand what Benchmark's Family Preservation Program is, because there's a lot of things that you can duplicate. My team that is here, can you guys raise your hands? So that is my lovely team from Benchmark Human Services that provides family preservation. We also have the Enact Mobile Crisis Program that we provide, and Chad's going to briefly touch on that here in a minute. I also want to share with you about family preservation because it is an evidence-based model. So recently, it received certification through the California Clearinghouse for Child Welfare. It's used across the state. It's a wonderful program, but like I said, there's a lot of things in it that you can absolutely duplicate without doing the program itself. Another thing is just identifying key strategies and interventions that we use in both programs to de-escalate crises. And then unique needs of mothers at different life stages. I think too often we focus on the new mom, right? But what about the teen mom? What about the mom that has someone going off to college, the empty nester? So I want to briefly speak on all of that too. And then lastly, just talking through what collaboration and community partnership can look like and the easy steps that you can take in order to do so. Is anybody familiar with family preservation? Sweet. Any providers? The Family Pres? Awesome, awesome. Okay. So about Family Pres, I know that this is a very text-heavy PowerPoint, but I wanted you to be able, again, to use this as a resource. That's why there's so much on there, okay? So first of all, family preservation is an in-home community-based service. So everything that my team does is in-home with the families that we serve. So we're meeting them absolutely where they are. We do not have a brick and mortar office that families come to, so this breaks down barriers for traveling, the stigma, think of the financials, And at times, childcare, right? Like we can't get to appointments because we don't have childcare or work. Additionally, the goals of family preservation is to not compromise the safety or the children or anyone else in the home and prevent removal. So our referrals come from the Department of Child Services all around the state of Indiana, as well as juvenile justice. In those families, we provide the same as what we do with DCS families. So we're involved only while that referral is opened, which kind of stinks, right? Because the challenge is I wish we could do family pres with those that were not involved with the system, because that would continue to decrease our numbers. Be great. Our target populations is anyone that's involved with the child welfare system. They have to be in home. So there are cases where we have families separated or temporarily. Like right now, we do have a mom that is at a 28-day treatment center, and so her child is placed with grandma, and then they can be reunited. We continue to provide family preservation during that time. And we look at mothers and caregivers in all stages. So it's not just moms. Like I want to take, yes, this is about mothers, but it's just caregivers. Like what do caregivers look like? It's not always a female mother, correct? And other key components is technically we are 365 days a year, 24/7. My team works very hard, makes a lot of sacrifices, but we also have a lot of flexibility in what we do in meeting families where they are. It's very strength-based and trauma-informed, so there's no nasty talk, right? Like we get used to the quote-unquote frequent flyers. Like that is not part of our dialogue. It can't be. It's exhausting. And then we provide all kinds of services, but just to generally speak, parent education, life skills, concrete assistance, case management, counseling, substance use, mental health, advocating. We have a lot of families that just have no idea where to start. How do I start cleaning my house? And so I do have some team members currently who are doing hand over hand with some of the families we work with to get their home clean so that their child can safely stay there. You got 2 slides.
I got 2 slides,
Yeah.
huh?
There you go. It's just
All right, I'm probably not going to pay attention to these slides. I'm just going to talk because that's who I am. So, just give you a little bit here. 2012, my son had a near fatal car crash. When that happened, I was working with people with intellectual disabilities. So the services came to me very quickly because I knew who to call. So when I was given the opportunity to build a mobile crisis team, that was my focus. I was able to find services because of who I knew. So the mobile crisis team needs to know who to call so I can make that pathway fast for anybody. And we've been able to do that through community partners. I'm in community meetings every day, everywhere, across 12 counties. We started off with 3, 2.5 years ago. We're now at 12 counties. What is mobile crisis? Mobile crisis is if you're overwhelmed and you're having any kind of crisis, call the crisis hotline. We are connected with 988, so 988 is a great resource to have somebody to talk to. We're somebody that shows up to help you when you're in need. What we're going to do when we get there is simply just take the time. First thing I tell my team is, everybody that we're going to go see probably has some kind of diagnosis. I want you to ignore that. I want you to know that there's a diagnosis, but ignore the diagnosis because that's not what we're there for. We're there for what is the need today? How can I help you today? How can I get you safe for today? So that can look many different ways. It can get you connected with outpatient services. Sometimes it's getting somebody connected with a church because that's what they need. It's whatever that person needs. Every individual is different. Kids with behaviors that we see all the time, it's taking a different look and trying to help that family figure out a different pathway because maybe they've tried everything. If I got time, I'm going to give a quick story. We had a 12-year-old that was very violent. He was hitting mom, throwing knives at her at one point, destroying the house. He'd been through family preservation. He'd been through wraparound. He had been through residential. He'd also been an inpatient several times. For a year, he was gone for over 6 months at 12 years old and still having these violent tendencies. We go out there and see him several times, 14 to be exact. Each time is a new puzzle piece. I look at these cases as a puzzle. And each time we get another piece to put together. And when we can put those pieces together, then we can figure something out. Well, I'd asked mom several questions about what had gone on in this kid's life. Found out eventually, after several visits, that he was shaken as a baby. Come to find out, he'd never had a medical workup because he had behaviors. So we're treating him for behaviors. He was diagnosed with autism. I asked where that diagnosis came from. The family physician said, well, he'll get more services if he has autism diagnosis. So there was no testing really done. He was just trying to get him more services. He had a bipolar diagnosis at 12. I said, where did that come from? Well, he went to Riley, and they couldn't figure out what was wrong with him, but they knew they could treat his behaviors better. If he had this diagnosis, they could give him different medications. So that was the whole premise. So long story short, he ended up getting a medical evaluation, found out he had a hole in his brain. So fluid was leaking into his skull. And what was happening was they were giving stimulants for ADHD, which was another diagnosis, that would push the fluids to his frontal lobe, causing the behaviors. Once they removed that, after 2 years, he is now back to school full-time. He was down to an hour and a half. He can now have friends over. His mom can work again. And one thing that he was very proud of, he had breakables in his room that he'd never had before because he'd break everything. So it was just taking that time. And that's what we do in mobile crisis.
If you want more information on mobile crisis as well as family pres, we do have a vendor table. Feel free to stop by. Chad has some cards. We're happy to talk through that a little bit more with you on what that looks like, because anybody can call that line. You don't have to be a client of Benchmark Human Services in order to do that. So back to family preservation. So this program started in June of 2020. So we're coming up on our 5-year anniversary. I came to Benchmark Human Services to be the director of family preservation, and it has rocked my world in the best way possible. I'm able to do things as not only a director, but also as a clinician that I would have never dreamed I would have been able to do in a brick and mortar setting because of how the program is run. So I feel like I can truly meet people where they are. That doesn't mean we don't have challenges. We still have the normal challenges that we run to. So we've served, not we, but the state of Indiana through family preservation has served 27,000 children and 14,000 families. The program has been recognized nationally, receiving designation as a promising practice. So this is an evidence-based practice if you are familiar with the California Clearinghouse. For child welfare, we can also use it for youth that are involved with the juvenile justice system. The program has contributed to significant reductions in foster care placement. There's nothing wrong with foster care, right? That's not what we're here to say, but we know that the research and data says if a child can remain in their home and we can support those families, they're gonna have a better outcome in the future versus removal and placement. So there's been a 50% decrease in the number of children in traditional out-of-home foster care, 50%. And then another 50% reduction in the number of children in residential facilities. So these families are staying together, but there's a lot of hard work that has to happen in order for these families to stay in the same home. Here are just a few, because I could talk about them forever. Key strategies and interventions. So this is included in family preservation, but this is really the language that my team speaks, that Benchmark Human Services speaks, and this is what we really look at when it comes to any service that we're providing. So communication techniques, what do those look like? Being considerate of cultural differences as well, going in there with a clean slate and trying to learn from that person instead of going there to just talk to them. Like, we really need to lean in to listen. There's also that mutual respect. There's so much stigma that comes along with the DCS referral and the probation referral. And I don't know if any of you know this, but usually 99.9% of the time, the referral has the mom's name on it, even if mom is not the reason for involvement. That has stuck with me pretty hard. And can you imagine just, having, and maybe you have had someone knock at your door from DCS, or you had to go to court hearing for probation. It's very condemning. And then we come around and they think we're DCS, and we're like, no, we are not DCS. They will stay out of your home if you let us in, and we can make things better. The other thing is building rapport. So simple ways to build rapport, right? Just when you meet with a new family, where do you want me to park when I show up to your house? Is there a place that I can sit that you're okay with? Is it okay if I bring my water bottle? Do you have any pets? Do you want my shoes on? Do you want my shoes off? Just be very respectful of the things that you would want in your own home. And it's so simple. And I think we easily forget these things. I go an extra step and I take dog treats to a lot of the families that I see, but that's just a little extra. There's also that with building rapport, asking permission. So not just asking permission on where to sit, right, and open your laptop and start doing all of our assessments and stuff, but is there permission for me to help you? What does that look like? And if we can get buy-in from that family, we're going to have way better outcomes. If you think about motivational interviewing, right, like revoking and evoking change. The next piece is trauma-informed approach. I feel like this is talked about, but do we really, really do it? If you have not been part of a trauma-informed training or approach with your organization, I would highly encourage you to do it. It helps to challenge and look everybody, like everyone can look in the mirror from top down, okay? And what does trauma-informed care look like? It's using people's names. It's not using the diagnosis, right? Like, those are the simple things that we always talk about, but there's much more to trauma-informed care. It's how I show up at your house. It's what time I get there. If I'm running late, am I gonna text you to let you know ahead of time? Am I gonna give you grace because you're running late or you missed an appointment? Is it frustrating? Yes, because that then goes into maybe my personal time or time that I have with other families, but knowing that you can have that lens of trauma-informed is great. And then meet people where they are. So having that open perspective, we can read everything possible on a referral, on an email. It can be hearsay, and I don't know if you know this as well, but the DCS referrals, probation referrals, that information can come from anyone. So it could be a plethora of stuff, and 2% of it could be correct. So we get that immediately, right? And then we get this image in our head of the family that we're going to work with. So it's really hard to separate things, but it's really important to go in with an open perspective and just say, I want to hear your story, whatever those caregivers look like, whether it's a mom, dad, grandma, grandpa. We see a lot of non-traditional at this point too. The other thing is being empowering, flexible, and authentic. So with family preservation, we can show up on Saturdays and other days of the week in a sweatshirt and sweatpants. Families are fine with that. There are times that we're at families' homes where they're having dinner, and I'm giving my own examples. So they've had dinner, and they told me ahead of time they're gonna have dinner, so I brought my dinner. So there's just this more intimate piece about it, and building that rapport, and sharing a meal with somebody is so therapeutic and so significant as well. And I talk about flexibility because it is frustrating when somebody's running late, or like today we're running a little bit behind on schedule. Like that, everyone runs on a time commitment, and it stresses people out and gives you anxiety. But you have to learn to be flexible because we're all human, and giving that grace to people is so important. And then, like I said, authentic, just I hope my team can be their true selves when we're meeting with families. I know there's times that we have to caution on certain things because we have to just be aware, and professional boundaries, right, code of ethics and all of that. But this program really allows you to be who you are and be authentic with the families that you're serving. There are times, more than not, that we are having uncomfortable but necessary conversations. So the families that we serve, it's talking to them about their history. It's talking to them about what's currently going on. And there are times that we have families that they have active substance use going on. There's active severe mental health that is not, it's not being treated at the time when we get involved. There could be domestic violence that is actively going on. And before, right, we would just pull the kids out of the situation. Now we're trying to rehabilitate. And so if you think of all the safety factors that go into that, it's a little scary, right? It's a little overwhelming. But again, meeting people where they are. And then concrete needs are met. So if I have one of our therapists, Tisha, goes into a home and the home has no food, the basics, okay, in the refrigerator, a little bit looks a little iffy, right? It might be a little expired, and then the cabinets are bare, and then we just see not clutter on the floor, but trash. There's trash on the floor. We might see feces from their pets. We might see feces from their pest. It could be a whole gamut of things. But how is she going to provide therapy? Let's say that's my home. To me, if I'm sitting in an environment like that, that would be so overwhelming, right? So we push for meeting the basic needs of our families, whatever that looks like. It could be financial, it could be educational, it could be the relationships. It could be like the financial piece. Let me go a little bit further in that. It could be somebody is getting ready to be disconnected. Maybe they don't have a cell phone because they left their partner and their partner was the one that worked and provided everything. So it's all over the place on what we provide when it comes to concrete assistance, but we want to make sure that those basic needs are met before Tisha starts providing that therapy. There's no way that I could be able to therapeutically process with her if I have all this going on around me. So it's not meant to be a shame, but to meet people where they are. And then the other thing is solidarity. So we have a shared responsibility to care for one another. I think we've really seen this with COVID, right? I won't go into the COVID soapbox that people do, but we have solidarity, and what does that look like for you? So take a look in the mirror and look at your organization too. What are you doing to help promote solidarity? And to break that down, that is having a shared responsibility. It's also bringing empathy and acting as one. So we work together as a team with those that we're serving. And then collaboration. I have a slide on collaboration, so I won't go into it too much, but just being considerate of collaboration is so powerful, and that's pretty much why all of us are here today anyways. I know that this is tiny. This is why I printed it out. So be considerate of the different life stages that mothers go through. I know we keep saying mothers, but please also think of /caregivers, because it's not always the mom that is the primary caregiver for the families that we are working with. So just a few things to be considerate of. Pregnant moms, the prenatal health and nutrition, what does that look like? I ended up having one of the families I served years ago when we first started went to my OB because she was on medication-assisted treatment, and I knew that my OB would not judge her. She was absolutely terrified to go in. Was it a lot of work to get her to those appointments? Yes, because she lived in a different city. She didn't drive. We had to transport. It was a lot, but she was able to have a wonderful birth experience. Prior to that, I just don't see that happening. So the discussions are happening more and more with providers, and it's not just OBs. I'm not knocking OBs. It's all of us that are part of the system. Other things is, do they have safe housing and financial stability? So we can help assist some of our families with bills they have to pay that are maybe disconnection notices, but what does that look like for sustainability in the future? So my team works really hard to empower our families to make sure that they have additional resources once we go out of the picture. Our services go out of the picture once the referral closes. And then postpartum moms, being considerate of what does that physical recovery look like? It's different for all of us, right? But also for our partners and the other caregivers that are helping. The exhaustion, I think we can all just relate to that in general in life. But there's a lot of physical recovery that we need to be considerate of. Parenting skills and early childhood development, again, being culturally sensitive to what does that look like. So sitting down with the family and asking them, what are your thoughts on this? I want to know and hear from you, like, how were you raised? How do you think you're going to raise your children? That doesn't mean it's wrong. But we need to have that open perspective so that we can have conversations. And then moms or caregivers that are parenting adolescents, the fun years. What does guidance look like on navigating through that development? It is all over the place. My kids are 5 and 7, soon to be 6 and 8, but I feel like they're adolescents, so I can't imagine what it's going to look like when they're actually in their teens. But things are always changing. So communication, support, non-judgment, what does that look like for our moms and our caregivers? There's going to be times that you're going to miss stuff on social media. You are human. Your job is not to micromanage over that being. There are things that we don't have control over. So give yourself grace on this, and also give the other mothers and caregivers around you grace. Mistakes are going to happen. Things happen. Also, just resources for academic and behavioral challenges. So Chad talked about Enact Mobile Crisis, but we have our community mental health providers, right? Northeastern Center, Butwin Center, Meridian Health, Park Center. Those are just to name a few. So we can also provide that support as well for the families, especially with the caregivers that are struggling with children that do have behavioral challenges. I just want to make sure I'm not repeating myself. And then academically, to go back to that, I'm a millennial, okay? So I'm 38, and you went to college. That is what you did. Like when you graduated, you went to college. That was not my parent thing necessarily, but that was the expectation at that time. So I think we need to be considerate of what does academics look like now for that person, and then what's the future look like for them. It does not have to be college. Not at all, right? Like we have trades, we have other professions, like there's plenty of things that you can do. So being considerate of that as well. So why does this matter? What we hope with the approach that we take with our families that we're serving is that we're providing better family outcomes. So the family is staying together, we're preventing removal of the family, and we're not compromising safety. We're reducing the interventions from child welfare. I don't know if you recently saw that there was an article like 2 or maybe 3 weeks ago now that the state of Indiana is 152 case managers short for the families that they serve. Right? Like it's hard. And we see all this positive data coming out of this program, but we're catching up on many years where we weren't doing what we could do. So keep having those conversations. And then this is ultimately improving better maternal health, and then stronger parent-child relationships. Whatever that looks like for that family, we want to embrace that, and we want to nurture that so that they are having better outcomes than what they would have had if we weren't involved. So community and collaboration, this is my favorite part. So lean in, and what I mean by that is get back to being human. There's simple things that we can do to support one another as caregivers. That could be if a mom is walking in or a dad is walking in with a child, open the door. Like, it's so simple. Don't be afraid to ask someone, like, can I help you? Can I help you do something? That doesn't mean you have to babysit their child or anything, but it's those simple things. If I see someone with their hands full, can I help take some of that for you? So get back to just being human with one another. I think on the downside, right, there was many downsides, but one of the downsides of COVID is that physical connection, right? We lost it, and we're very cautious of it now, as we should be. I'm not saying anything against that, but we're almost afraid at times to have that connection with one another. It's very simple to just be like, it's good to see you, or ask somebody how they are, and just simply say, how are you? And listen, just be engaged in that conversation. The next thing is keep talking. So have the uncomfortable conversations. If there are things not working in your organization or with your team or with yourself or other organizations that you work with, have those conversations. When we initially started the program, we would have debriefing sessions after a case would close. That would not include the family, but it would be my team, myself, and then DCS or probation. We would talk about the good, the bad, and the ugly. Let's talk about it. How do we fix it for next time? What do solutions look like? So it's very solution focused. So don't be afraid to have those hard conversations on, this is ugly right now. What can we do to make it better? And then share the good, what is working, and that also leads into no silos. So if there are good things working, AKA family preservation, share it. That doesn't mean you have to adopt the entire thing, but there are elements from it that you can absolutely do in everyday life. We also don't ever really share good news, so, especially in this field. And then examine your habits. Is what I'm doing supportive to my beliefs and those that I serve and to myself? So what does accountability look like? What does that reflection look like? Yes, you can go to supervision. Yes, you can have one-on-one supervision. You can go to your own therapy. But really taking that time to self-reflect on what are my habits and are they helping or hindering the process? It takes one person to provide hope to somebody, one. I do a lot with suicide training. It takes one adult, that's it, for an adolescent to be successful and have better outcomes, even if it's not their parent. So sometimes I know that my team is challenged with, at times, families do not engage where we would like to see them, so we have to, circle back and meet them where they are. But ultimately, during that time, they are consistent, that person, and they're still showing up even if they're late, even if the house is messy, even if somebody's grumpy. You're still showing up and being consistent, and it just takes one person. Shared responsibility. So think of us as a pie, right? Whatever all of you here are affiliated with, personally and professionally, like you're a piece of the pie. So there is this responsibility, right, with solidarity and shared responsibility that we are here to support one another, especially the caregivers that we work with. And then storytelling, which I kind of mentioned this earlier, the good, the bad, the ugly, share. I know that we have to be conscious, right, of HIPAA and confidentiality and all those things, but there are things that you can share internally. Share the good stuff, though, too, not just the challenging stuff. And then visibility, what does that look like? Are you showing up to events? Are you telling people what you do? Are you trying to find a way to have these conversations? And I don't have to be like, hi, I'm Megan and I'm a licensed mental health therapist, but I can just be like, I'm Megan and I attended this conference, or I'm Megan and I have a kid too. Like, let's talk. Thought I could see, but I can't. Ugh. Education. So education would be what you're doing today, the conferences, and then also offering guided discussions. So don't be afraid, especially with the caregivers we serve. In my perfect world, I would love to be able to get the caregivers of the families that we serve in one room together, but we're all over the state, so I don't see that happening in that fashion. But can we have guided discussions, and what does that look like in providing just a safe place? It's not therapy, it's just a community discussion. So lastly, I just want to wish all of you and anyone else, to all who are mothers, regardless of your gender, thank you for everything that you do. Celebrating mothers and those who take on the role of mothering. And I also want to acknowledge everyone who identifies as a mother today. I really appreciate what you do. I also want to acknowledge my mom, who is out there. Hi, Mom. And I am available for, I don't know on time, I know we were running behind, but maybe a couple minutes for questions if you have anything for clarity purposes. Yeah. No. Womp womp, yeah. Benchmark itself is continuing to expand our services with like DCS and so forth, but right now, family preservation can only go through DCS and or probation. But again, that doesn't mean you can't call and consult with us and be like, hey, like, this is the kind of case we have. We'd be happy to tell you like maybe some of the things that we would do and what that looks like. And DCS does have a good website related to family preservation. There's a ton of information on there. Yeah, there's a ton of providers. So there's at least 7 providers in every county in Indiana. So it's very competitive. But they do it based on what services you offer. So we fill out something saying we offer this intervention, this is the staff I have, this is what we look like and what we can provide to the families. The families at times, we've had some families come back, again, like circle back to us, which is fine because we can continue the continuity of care with them and start right back where we left off. There are times, though, too, that DCS and our probation just has their people, and so that's where the referrals go. But in the service standard, it says that the family has choice. But if you've never been involved with DCS, right, you'd be like, who's benchmark? Like, that's not. So we do not technically offer the wraparound program. Northeastern Center does have wraparound program. I know that Chad's program intertwines with wraparound. If we've had a couple families that are part of wraparound, and we just sync up with them. We're supplemental. We don't take over what they do. We are just supplemental to them. But you brought up a good point. It kind of looks like wraparound, not like, yeah, not the financial side, but like what wraparound looks like and the purpose of wraparound, it's very similar. And I think a lot of my team uses the word wraparound a lot too to describe services. Any other questions? Thank you for your time. I appreciate you being here. Have a good day.
Recovery. So we're excited to have them present today. And after their presentation and wraps up in questions, you guys can head to the gymnasium and we'll have lunch. Thank you.
All right, I'm trying to figure out the best way to see somewhere, so I think I'm going to put my glasses on and just watch here. So we're going to talk to you about Meridian's maternal treatment program. This is a program that was developed to enhance recovery outcomes for mothers and their babies. MTP, as we like to call it, is an integrated program. We combine mental health and physical health, and then also focus, especially initially, on substance use treatment. It's a program that's designed for women who are either pregnant or have children under the age of 5. And the programming can be combined with any other existing treatment plans in our agency. Some of the components that are really important in the maternal treatment program, of course, the substance use treatment, also medical support and education during their pregnancy, prenatal and postnatal care, individual and group therapy. We do take that trauma-informed approach that you've heard others speak about today. We focus also on child development, parenting education and resources, nutrition education, financial independence. There's a point system for the women in the program to earn points based on activities that they participate in, and then they can spend those points in our MTP baby store. There's a lot of research out there right now about contingency management programs, the benefits of them, and how it really works to provide positive rewards for positive behaviors to lead toward more long-term behavioral change. And then also we have, we intervene with the spouses or other family members, the children, and provide referrals as necessary. As we get into talking about some of the curriculum, you'll see that this is a program focused solely on mothers, on women. But we do have the ability to use all of the curriculum if there's someone else in the family, whether it's a male partner, transgender partner. There's ways that we can use the curriculum to assist them as well. And with the children, we use the ASQ 3 developmental screening periodically throughout the program so that we're helping moms identify if their child is having some sort of a developmental issue and making appropriate referrals for those. It's a 3-phase program focused initially on that whole person health, the physical, social, emotional, and behavioral needs of the mom. As I said, there's individual and group therapy, and this phase of the program focuses a lot on supporting their recovery. In phase 2, they move more into parenting skills. And then phase 3, we're going to focus on that community connection. So what that looks like, during phase 1, we use the Recovering Together curriculum. Again, this is focused primarily on the addiction and recovery pieces. It's about 16 weeks, and I say about because things happen in life. Sometimes babies are sick, sometimes moms are sick, sometimes there's another reason why they might have to miss. So it may take them a little bit longer than 16 weeks as life kind of plays out. They come twice a week for 2 hours. That is the group, but they also are involved with individual therapy during that time, so they're getting those collaboratively. As they move into phase 2, we use the positive discipline curriculum, and these are evidence-based programs that are approved through the California Clearinghouse. That's really important because a fair number of our referrals come from the Department of Child Services, and it's very important that they meet those standards. When they're in phase 2, it's a 12-week program, again, approximately, if they don't miss any. That becomes a 1-week group therapy for 2 hours. They are still involved in individual therapy at that time as well. And then phase 3 is very individualized. It's a minimum of 6 weeks, and I often call this kind of putting the nice bow on the package at that point, making sure that we've solidified their community supports, that we have them connected to the resources that they need so they can transition out of care into more kind of the organic development of their own recovery at that point. They may continue in individual therapy. They may also be a part of our relapse prevention programming. You'll see in the picture here, and there's a short video here in just a second, this is not your typical group therapy room. I mentioned that this program is for pregnant women and women with children under the age of 5. That group is identified because those are pretty much kids that are not in school yet. After about the age of 5, most of their kids are going to be in school. But when they have those younger children, they come to the program with them. So we have our group therapy room for MTP set up very differently than most group therapy. This is about a 2-minute video that is a walkthrough of one of our programs. I think it has some audio with it, but I'm not sure how well it's going to play.
So here we have our maternal treatment room. As you can see, we have plenty of little seats and bouncers, bassinets for the moms to use with their babies when they come in for services. We have a table that they can use and gather around while they're working on their programming, and another area where they can sit around and discuss what's been going on. We have a play area for the children so that they can have something to do while moms are participating in group. We have a little refrigerator, so we have snacks for them as they come in. Moms can bring their babies in and their children as up to age 5. Over here we have some cabinets for our baby store and for the moms as well. So moms can earn baby bucks, where they can come and purchase items either for their babies or themselves. Of course, diapers, if those are needed, we always provide those for the children. Just more items. We do like to keep some things for the moms themselves so that they can, purchase some hygiene items if they would like those. And so they can earn these bucks by participating in group. And again, just more clothes and everything like that. We made this a very welcoming environment. Changing tables. So we just wanted to share what our MTP looks like.
So kind of a quick run through there of a tour of one of our rooms. They are set up very similar. And again, the baby store has items for mom to help prepare for the baby or take care of the baby after it's born, but also some things for her. Some things that she may need or just want for herself. Along with our maternal treatment program, a lot of our moms are involved in ancillary treatments at Meridian also. That may be things like our intensive outpatient treatment, medication-assisted treatment, our women's recovery home, again, individual therapy, and our peer recovery specialist. With the intensive outpatient, it's a program that has 2 distinct phases. And the goal is to provide effective long-term treatment for their recovery. Initially, they're in 9 hours per week, three days a week, 3 hours at a time, and approximately 8 weeks. Once they graduate from that, they move into the second phase, which is an hour of relapse prevention for about 12 weeks. For most women, we don't recommend that they do MTP and intensive outpatient at the same time. There is one exception to that, and I'll talk about that in just a minute. With the medication-assisted treatment, using medications in combination with counseling and other behavioral therapies to provide that whole person approach to the treatment of their substance use disorder. There's a lot of great evidence of the benefits of MAT, and it's definitely a service that's trending upwards. Just in January of this year, Meridian was able to provide medication-assisted treatment to over 500 patients across our agency. The Women's Recovery Home, this is a residential facility that we have in Muncie. It's a structured 2-phase residential program for women who are struggling with substance use disorder. Women who live here are the exception to the participation in MTP and intensive outpatient at the same time. Because it's a residential program, daily programming is an important part, so having them attending MTP 2 days a week and IOT 3 days a week gives them that daily programming that they need to support that. This home also uses a holistic approach, strongly focuses on women and their children. There is the ability for women to, in certain circumstances to be able to bring their children to the home with them. And again, we've got a short walkthrough. I know this one does not have any audio other than maybe a door shutting or opening here and there. But give you a quick look at the Women's Recovery House. And again, this is in our Muncie location. If you're familiar with group home living, it's set up in much the same way that a lot of other group homes are. Some of the bedrooms are shared. If a woman's able to bring her child or children with her, it was very likely she would not share a bedroom. But there's shared living space, shared eating space, meeting space, and then also the individual rooms, bedrooms and bathrooms. Creaky old stairs. So in addition to the services that are provided at Meridian, we also collaborate with a lot of community resources to make sure that the moms are provided with childbirth education, lactation education and support, infant CPR training, baby care basics including safe sleep practices, car seat safety. There's a postpartum support group that we can connect them to, and we have connections to sibling and resources for grandparents as well. So what's really important is not just that we have this program, but that we know it's successful. We know that it works. So I've given you a couple of examples here. The individual and growth and recovery can vary, but these two examples are great successes that we've seen out of this program and mirror the other successes that we've seen. So with the first one, this mom was struggling with substance use while she was pregnant. She was enrolled in MTP, took a brief hiatus from that, and went to inpatient substance use treatment, and then returned and finished the MTP program. Her baby's health, the baby was born without any substances in his system. The baby was returned to mom's care during her engagement in the maternal treatment program. And as of the development of this presentation, she'd been sober for over a year thus far. So pretty remarkable. Another example, mom had already been involved with DCS with some of her prior children. Her treatment path is that she was involved in maternal treatment program and also that was supplemented with medication-assisted treatment. Her baby also born without any substances in his system. He was initially removed by DCS because of the prior involvement with them. But throughout the course of her treatment, while she continued with MTP, he was returned to her care. He was reunified with her. As far as her ongoing recovery, mom has been sober for over 1 year and is now thriving in phase 2 of our program. So pretty neat outcomes. We've got many other great stories like that. And it's always exciting not to just have a program that we know does good things, but to see it actually working in people's lives. So our current locations for a maternal treatment program, we have them in Anderson, Lafayette, Muncie, Newcastle, and Richmond. Richmond has a pretty unique collaboration with their local hospital, and Katie is going to talk about that in the next few slides. So this is Katie Vance. Katie began her journey with the project, the collaboration is called The Nest. So she began her journey with The Nest as an operations coordinator 3 years ago. She's driven by a passion for supporting mothers in their journey to be the best that they can be. Her career in the medical field started 9 years ago as an office assistant, eventually progressing to medical assistant, and then to managing an entire medical department. Katie brings a blend of personal experience and professional growth to her work, and we're really grateful to have her.
Thank you, Jody. Okay, let me get my notes pulled back up here. I am originally from Chicago, so I'm a fast talker, so I'll apologize ahead of time. My mom still to this day, slow down, I can't keep up. Okay, so the Nest is a partnership between Reed Health and Meridian Health Services. We opened up in 2020, and what we did is we saw that Meridian already had this great MTP program, but what else can we do to make it even better? So we partnered with Reed Health, and we brought OBGYN services into it. So Reed Health brings all the comprehensive OBGYN services into the Nest in one location. They can do everything on site except for ultrasounds. So they do the blood draws, they do all the checkups, prenatal, postpartum, and everything from there. So we partnered with them. Meridian provides, just like Jody said, everything on the behavioral health side. We have the group therapy, the case management, peer recovery specialists. And what we wanted to do was really just like break down all the barriers. So Meridian provides case management to break down the barrier of transportation. See, I talk so much, I don't even realize I have a slide here. We do pride ourselves on the fact that we let the women bring the children to groups. So the Nest has 22 women, and sometimes we have 8 women sitting on a couch, and there's just like children running a track. But you know what? One thing that is going to help them survive and thrive in recovery as a mom is learning how to do it while you're being a mom. We understand that's not the case for everyone. Every case is different. We have an LSW who leads the group. She has experience with substance use disorders and childhood trauma. She worked at, I don't know if you've ever heard of the JC House. It's a child advocacy center in Richmond. She worked there for years and brought that with her. And she saw that a lot of like DV and childhood trauma and different things like that can kind of be the root to the substance use. So we offer groups just like MTP program does, but we also offer codependency group. We offer the recovery group, parenting group, codependency, and relapse prevention. Reed does all the MATs and OBGYN services, so they are seen weekly by Reed. They come in, they do their drug screen. If everything is cool and kosher, they get their script, and we'll see you again in another week, but we still try to touch them. We are an outpatient treatment program, but we understand that sometimes we need support as much as we can. Unfortunately, we are only open Monday to Friday, but we hook them up with services then on the weekend if we can. So let's see. Reed does Subutex during pregnancy just because it doesn't have that naloxone component to it. And then 6 weeks postpartum, they can see then a different nurse practitioner who will continue on with Suboxone if they would like. Not every patient is on any form of MATs. The majority of them are. We also have some patients who come to the Nest just for the therapy aspect because, say, they get MATs from a different service or they don't want MATs, and vice versa. Sometimes, you know, people are like, oh, I'm not ready for therapy yet, so they can come and they can just see the Reed services and, hey, when you are ready, we're here. We have a huge partnership with Reed Community Engagement. We are heavily grant funded. We actually opened up the Nest with a DMHA grant. That ended 2 years in, but now we are grant funded and we can do things with grant money like cooking classes. We do financial, there's been a couple months where some women are like, I just need to get a job, but I finally got this house and can you help me pay for it? Absolutely. If you're compliant, you're doing what you gotta do, and you can, you know, we can kind of work through what your next steps will be. I'll pay your rent for 3 months if I have to. As long as you're doing what you have to do, we are here to help you in every way that we can. That is pretty much what we do. I got some stats for you here. Off the top of my head, I do know that since we've been open since 2020, that 89% of our women through the Nest have been able to keep their children in the home. Some of them come to us and they have already lost their kids from DCS, or some still, but that is our goal, to keep the children within the home. In 2019, about 36% of people that delivered at Reed Health tested with a positive drug screen at time of delivery, and then come 2020, 2024, 20.4% of mothers delivered. So that's almost 12% less in just 4 years of us being open. So we pride ourselves very, very heavily on that. The next one. We also have had no babies born with neonatal abstinence syndrome since we have been open. Oh, there's my fun stat of 89%. And then go to the next one. Yep. Okay, just go to the next one. Here's a couple pictures for you guys. We look very similarly to the other locations. We have just a big, massive couch. You come in, you sit down. We try not to look like a doctor's office. I mean, I don't know if you go to a doctor's office, but I feel horribly uncomfortable. It's just cold, it's clammy, especially the sick, the germs. So you come in, you got this big open couch, sit on the couch, be comfortable, hang out, wait for your appointment, and then we'll see you from there. The middle picture is a picture of our we call it a baby boutique. So like Jody said, every service you come to, you get at least one baby buck. Your DCS closes, I'm gonna give you 10 baby bucks. You deliver your baby and everything goes well, I'm gonna give you more baby bucks. I know I work a little harder if I know that I am a little rewarded, so we try to do what we can. We are heavily grant funded on this as well. We have a nursery that we can teach swaddling, safe sleep, different things like that. The Read team is also certified in car seat safety, lactation consulting, and things like that, so we do all of that in-house at the Nest. And here's our contact information. So the Nest is in Richmond. We are the only partnership within the Meridian MTP programs, but hopefully one day we'll all partner up. Anybody have any questions? Everyone ready to eat? Thank you, guys.
What does time. But it is going to allow me to kind of move through some of my slides so that we really get to the meat of, I think, why we're all here today. So I'd like to just introduce myself, that my name is Dottie Fuentes. I'm a licensed mental health counselor, and I've spent the last 25 years working in community mental health, serving individuals that may have gone without treatment. This work has been both my calling and my commitment. I'm the proud mother of 2 teenage boys. I got nervous there when I start talking about my kids. And a stepmom to an amazing 27-year-old. Okay. I'm the daughter of a certified nurse midwife who has instilled in me a deep understanding of the challenges that women face in accessing health care, which I think has been so evident today as we're like talking about it and hearing those women's stories, and like thinking about, you know, how many of us as providers, we want to say the right thing, we want to do the right thing, we want to help, but I think somewhere we kind of lost our way a little bit. I think that we have forgotten about being human. We've forgotten the importance, and I think Megan kind of alluded to it, we've forgotten the importance about connection, that we have set all these rules as professionals, what we can do, what we can't do, and again, there are boundaries, we have ethical responsibilities, but we've almost lost the human side of treatment. But long before I became a mother myself, my mother was teaching me about the miracle of pregnancy, teaching me about the power of childbirth, and the extraordinary capability of women's bodies. Her advocacy for women during pregnancy really laid the foundation for the passion that I have in my work today with mental health. My ACE score is a 1, and I recognize the privilege of having had such a safe and supportive childhood. But that perspective has given me an approach to treatment as a clinician, that I approach my clients with humility and respect, which is probably why I get so emotional hearing their stories, right? I get choked up. My counseling career began as a community-based case manager, and then I pursued my master's degree in mental health counseling. Over time, I developed an interest in dialectical behavioral therapy, specifically working with women in trauma, addiction, individuals involved with child protective services. And that's really where it, I'd say, fueled my passion to do something better, right? To be, as a provider, to do something different than what we have done in the past. Today, I have the opportunity to serve as an administrator for the Northeastern Center, which is a community mental health center, serves Steuben, Noble, LaGrange, and DeKalb, so just a little bit north. But my job as an administrator now is really to transform the systems. I believe that we can and that we must do better as providers. But in order to do so, we have to understand the impact of trauma. And when I say understand, it means really understand. And so as I was putting this PowerPoint together and asking myself, what does my organization do to make sure that we don't re-traumatize individuals? I have no doubt that all of my team members care deeply about the work that they do. None of us would be here if we didn't, right? Our work is hard, and it's not about passion. It is really about challenging ourselves, challenging our beliefs, challenging the way we see the people we serve. And so that is going to be our focus for this presentation, and really asking the idea of what would a trauma-informed community look like? And I love the vision. And so thinking about, if we've all heard the term trauma-informed communities, what do we think of when we think about trauma-informed? It's like a buzzword right now. What's trauma-informed mean? Not assuming that you know somebody's story. Having the resources when somebody talks about their trauma, right? When they open up and they share it. Yeah, And we're going to talk a little bit about that, but I challenge myself often because I get stuck in that. I still get stuck in that. You know, I get stuck in that with my kids. I get stuck in that with the neighbor kids, you know. My nephew, I think, what is wrong with you? I say it in my head, you know, he's a little wild. So we really have to challenge those things that we've always done. And I love the idea of a trauma-informed community and what that means, what it really means. So we're going to talk about it today. I would really like to make this an interactive conversation to brainstorm on how do each one of us take this idea and spread it to our systems, to talk about it within our families. It's not just about providers, right? I need for my husband to understand what a trauma-informed community looks like. I need him when he's interacting with kids on the baseball team. I need him to understand what that means. I feel like I should also mention, I was recently elected to the Garrett Kaiser Butler School Board, and this is a big part of why I ran, because I believe that our school systems have to do better. They're doing the best that they can, but I believe that there is a different approach, and our teachers need to understand, our administrators need to understand. We need to look at policies and say, are we re-traumatizing our kids from policies? And in my 5 short months on school board, I would say yes. Yes, we are. So I'm really going to challenge myself, and I would encourage you guys to challenge yourselves and each other. Okay. All right, so our agenda for today is to really look at what is a trauma-informed community, what does that mean, understanding how women's trauma impacts childbirth, impacts pregnancy, and I think that was something else that I heard a lot of so far this morning. We cannot ignore the fact that women's health care is different. We are treated different by our providers. The expectations are different, and we, as a provider, I need to do better, and I need to acknowledge that. We need to acknowledge the differences for our marginalized friends, for our LGBTQ+, for our friends, people of color. We have to do better, and we have to be willing to have those uncomfortable conversations. Okay. We want to look at trauma during pregnancy, birth, and postpartum. We're going to talk about that and talk about, as providers, what can we do differently. Okay, trauma-informed care. So what difference does trauma-informed care make? Why do we care? We have to start by understanding that everybody experiences trauma. And we're going to talk about the ACE. I mentioned earlier that my ACE score is a 1. But this is not about, trauma-informed communities are about acknowledging that everybody experiences some level of trauma. And that we have to acknowledge that, recognize the impact that it has on our friends, on our neighbors, on our siblings, on our parents, so that we can change the way that we approach individuals. It is about recognizing the symptoms, creating a safe and supportive environment for people. It is about making sure, somebody said it earlier, what happened to you, and really taking off that lens of judgment, which is easier said than done. If we're really honest about it, we probably have to bring ourselves back every time we see another client, every time we interact with somebody, because that is not how we approach situations. It's also not how we approach situations as clinicians. Our job as clinicians are to gather enough information to give a diagnosis, because if we don't give them a diagnosis, insurance companies won't pay for it, right? So it really challenges what we are supposed to do at the core. Okay. So the key principles of a trauma-informed community, I'm going to jump over here so I can read this, are about safety. Safety is the first step. It's psychological safety, it's physical safety. Think about the last time that you were at a store and you walked out and it was dark and the parking lot lights were off. Maybe they just burned out, right? And you feel that heightened sense of maybe a little anxiety. Maybe you have been the victim of a crime. You might have a little bit heightened, but probably all of us as women have a little bit of anxiety about it because we feel susceptible and vulnerable to crime, right? Vulnerable to being attacked, being robbed, all of those things. So it's physical safety, psychological safety. As you think about your work environment, do you feel like your office sets up physical safety? I know there are things that I could do, that my office could do differently. So thinking about that, it is about being trustworthy. Oops. And transparent. What does that mean? I feel like our friends in there on the panel were just kind of talking about that. What does it mean to be transparent and trustworthy? Like really mean. Means having those tough conversations, right? It means if you feel like you can do it, you need to tell the parent, hey, look, I'm going to have to call Child Protective Services and report this. I'd like you to sit here with me while I make that report. Sometimes that's not appropriate to do, and I recognize that. And it feels really scary to do that in front of a parent, but that's how we build a real relationship. It is about being honest. I don't know what it's like to be addicted to heroin. I'm not going to pretend like I do, but I'm going to walk alongside you. You know, it is about peer support, which is so incredibly important. And as professionals, we need to do better at supporting our peers. In my opinion, we have encouraged peers to be part of the professional team, and yet I see so many professionals that don't treat them like equal members of the team. I just learned a ton from these two ladies in here who are willing to share their story, you know, but yet there is so much stigma attached to it. So we as professionals have to start acknowledging the role that peers play, and recognizing that peers sometimes are way more important than me being a licensed mental health counselor. And we probably need to take the back seat and let the peers teach us. It is about collaboration, encouraging that shared decision making. It's about empowerment. And I'm going to put those two together. By collaborating and being a partner who does something with the people we serve, we're empowering them to get to make choices. It's about saying, you know, a lot of times when I worked with parents that were referred by Child Protective Services and they felt like they had to be here. They were forced into treatment. They don't even want to be here. But pointing out to them that they made a choice to come in here to my office. They can come in and be pissed off about it. I'm okay with it. I'd be mad if DCS came in and criticized everything I did too. Because that's what DCS's job is, to come in and point out all the problems, right? So it is about empowering them and helping them see where they're making really good decisions. And we can't ignore the cultural, historical, and gender trauma that people have experienced. If we think about this idea of trauma-informed communities, we need to recognize that everybody comes in, everybody we interact with has a heightened sense of alertness because our world is traumatic. So if I'm a little crabby when I come into work on Monday, I need grace, right? Maybe I had something really bad happen over the weekend, or maybe it's just kind of where our world is at. We cannot ignore the historical trauma that is passed from one generation to the next. Because somebody may not have been there that day, but I think about like the story of George Floyd. Those people are going to remember that moment forever, and they're going to tell their kids about it, and those kids are going to experience intergenerational trauma. We cannot ignore that. All of us, probably most of us in this room, I think, could remember 9/11 and what that day was like. My kids were not there, but I tell them about it every single year. This is what it was like for me. You know, my mom tells me about the day Kennedy was shot. So even though I wasn't there, I experienced some of that. So trauma-informed care, those 6 principles are our framework. Hey, Jennifer, what is our time for the next speaker? Oh, okay. All right, thank you. So in the 1990s, CDC and Kaiser Permanente did a trauma study, which is really, it's 2025, and I feel like we were so late to the party, right, to really understand the impact of trauma. The Adverse Childhood Experiences Assessment gathered information from 17, I'm sorry, I kind of got my notes messed up. I think it was 17,000 people from middle-class families, asked them questions about their childhood. And what they were looking at was trying to figure out how adverse experiences during childhood impact overall health. So several speakers this morning have talked about how we can't separate addiction from mental health disorder. We can't separate addiction from post-traumatic stress disorder. The research shows us there are very few individuals who just have an addiction. That doesn't really happen. And so, but we have treated it that way as professionals. But that's another presentation, right? So I'd like to share this video with you about the Kaiser Permanente research and talk about what we learned and how do we use this at this idea of building a trauma-informed community.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente, set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. And Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
So some of the example, how many people have done an ACE assessment on themselves? No, okay. I would encourage you, you can find it on the internet. It's really easy, but I'd like to read for you what the study, some of what the study found. Adverse childhood experiences include experiencing violence, abuse, or neglect, witnessing violence in the home or community, having a family member attempt or die by suicide, substance use problems, mental health problems, instability due to parental separation, instability due to household members being in jail or prison, right? There are other examples, but those are not like 9/11, right? Those are experiences that probably a majority of us have experienced at least one. And so if you started asking, what if everybody did an ACE when they got enrolled in school? What if we started doing ACEs in the school annually? What if every time I go to my doctor's office, when they hand me my HIPAA form that I have to sign, every single time they hand me an ACE? What would that do for women's health? How would we treat women differently? How would we prepare? And I'm going to jump forward through my presentation to get to the pregnancy, labor, here. But if we think about, so we know that women experience trauma, right? We do know that. We know that childhood trauma impacts brain development. It impacts how you see the world. And then it leads, right? Then you become an adult. And people expect that your childhood traumas don't really affect you anymore. It's a long time ago, right? We have all these things. But your body remembers. The body remembers those traumas. It's etched in your brain, even when our clients don't want it to be. It's etched there. So I would like us to think about women in pregnancy. Kind of going along with some of what we've already talked about this morning. When women are pregnant, we expect for them to be super excited most of the time, right? It's supposed to be this time of celebration, and what a blessing, and all of these things. But how triggering is it? Just the experience of your doctor's appointments, right? I hate going to the doctor. I absolutely hate it. But with pregnancy, you have to get over it real quick, right? So for somebody who has experienced any sort of sexual abuse, sexual trauma, and if their OB doesn't ask that, are they going to approach it? They're going to approach it just like they would with anybody else. So again, if we started implementing the ACE, providers would treat women differently, right from the beginning. Okay. So trauma exposure, let me just move on to this one. All right. So examples, trauma doesn't go away, right? When you become pregnant and everybody's throwing you baby showers and everybody's so excited for you, your body remembers that. Examples of trauma during pregnancy. Can anybody think of any? What would be examples of trauma related just to pregnancy that a provider would want to know? What was it? Yeah. They're going to want to know childhood physical abuse as well as current, right? We're going to want to know partner violence. We're going to ask about previous pregnancies and what that was like. And it's not just about their medical history, right? It's about what was your birth like for your first child? It is, what were the medical complications? Anybody think a high-risk pregnancy is a traumatic experience? Because it is, right? Loss of autonomy. You get super sick and suddenly the doctors are making all of the decisions for you during pregnancy. You're on bed rest, right? You no longer get to make choices about your health care. Somebody else is telling you what you need to do. And everybody always has an opinion about what pregnant women should be doing or shouldn't be doing. Certainly the trauma with unplanned pregnancies and the stress that causes. During labor and delivery, unexpected medical interventions, again, the loss of control, extreme pain. What do we know about, what does pain do to the brain? Right? So I'm starting out here because I'm nervous because it's my firstborn. I have no idea what's going to happen. I have all these ideas in my head of what I'm going to do during labor. The pain pushes me up here. Now my anxiety's up here, right? Am I going to be able to cope if I don't tell? If nobody asks me, I assume there's something wrong with me. Other examples would be disrespectful staff. This is another whole presentation. Women during labor and all of the things that they are told they have to do, will do, should do, can't do, unless you are lucky enough to find a provider that allows you to make those choices. And that's hard to find. And it's particularly hard for women that are on Medicaid. People that have resources have a lot more options in their health care. Separation from the baby immediately after birth. That is a traumatic experience, and we know that it disrupts bonding, but yet we do it anyway. That is part of the process for so many. I think, do we have some nurses from labor and delivery or something? Yes. Is that still pretty common? That's the practice, right? For what? Try not to. It is really common with a C-section, which I don't know what the statistics are, how often people go in thinking they're going to have a vaginal delivery, end up with a C-section, and now that changes everything. All of the plans that I had for this 3-day stay, right? So that experience, again, is another example of the trauma. And then we've got postpartum trauma. The isolation, wondering what's wrong with me because I'm not excited about this, wondering what's wrong with me because the baby cries all the time. I cry too. And just that feeling of isolation, not knowing what to expect, what are their supports. So what can we do about it? I think it's acknowledging that women's health have special needs, and we need to advocate for not just ourselves and for our daughters, but for our neighbors. We need to hold providers accountable, including each other, right? Somebody hold me accountable. Make sure that I am being present and challenging the systems that I work within to serve people better. We have to acknowledge that women have special needs and stop taking a back seat. Collaboration. There was a lot of discussion this morning about collaboration and the importance of we can't work in silos. I'm a mental health provider, but I could count on one hand how many times I've called an OBGYN to coordinate anything on behalf of my client. It'd be 0, if I'm being honest. We need to do better because that's what helps the people we serve. That's what helps our community. Encouraging people healthcare providers to do assessments. Again, this idea of everybody completing, in every system, completing ACEs. How would that change our interactions with one another? So, lastly, I wanted to focus on the idea of a holistic approach, the collaboration of care, empowering women through education, which is what we're doing today, right? Thank you, Jennifer, for this awesome opportunity, bringing everybody together, because what a great way for women to talk about it. We have medical staff, clinicians, I don't know what all we have, We have a lot of different types of providers. And I think at the end of the day, what we have to look for are ways to transform maternal mental health altogether. That we have to bring it to the forefront because we have little ones that are counting on us to help them be better, right, for the next future, for the next generation. I keep telling my kids, like, I'm super excited to see what they do with the progress that hopefully we have made. And they're going to blow us out of the water, right? So I appreciate it. Sorry, I flew through some of this. I wanted to make sure that we were able to talk about this idea of a trauma-informed community and really advocate for us to be the change. And appreciate, again, the opportunity to bring all these people together from different backgrounds so that we can look at, it's not enough just to know the information, but it's coming up with a plan so we can change it. So are there any questions? All right. Thank you, guys.
So a fun fact is that Dottie and I are working on completing our certificate in fundraising management together through a collaborative effort from some amazing foundations in the community and in other counties. So anyways, thank you, Dottie, for being here and presenting. I think our other breakout is wrapping up around 1:30 as well, so you guys just have a few minutes. Once they get over here, we'll get started again. So thank you, guys. I think we're ready to get started with the last piece of our afternoon. And again, I just want to thank you guys for staying, for like committing to 2 days to this. It's very hopeful, and I feel like it's something that we're going to have our eyes set on for next year as well. So just a little note about that. So thank you guys for coming. For people who came yesterday and stayed overnight and came today, or however you came here, please know that it's so appreciated, and I can't wait to hear about how you're able to take it back to your own communities. So just thank you very much. I have the next speaker. If you were here for our seminar in September, she was a big piece of that and very, very well received. And just a force of power in the substance use disorder community, specifically for mothers. Her name is Brooke Schaefer. She's the Senior Vice President at Volunteers of America, Indiana and Ohio. I'm super excited. She's going to bring a lot of energy, so everybody will be ready for that. All right, thank you.
Okay, so frequently got on my report card like talks too much in class, or was extremely hyperactive, or is bossy. Did anybody else get that on their report card? Yeah, so anyway, I'll try to behave a little bit. I did set a timer because I want to be a good steward of your time. I'm sure many of you are ready to get home, so I appreciate you staying for this, but I promise that I will not go over my half an hour. I am a very talkative person, but I will behave myself. So let's see, very good. All right, so I'm Brooke Schaefer. I am a nurse practitioner. I'm a family nurse practitioner. I also have an MBA. I got that MBA because my daughter went off to college, and it was either like do something really big or lose my mind with her not in my house. So I know we're talking a lot about motherhood today. That was the child that made me a mother. So when she went off to school, I knew I needed to, I always punctuate big moments in my life with doing something crazy to distract myself from that big moment. So when she went off to college, I decided to get an MBA. The good part about that is, though, that I've seen this beautiful blend, and I'm seeing other providers with similar concepts of, it's nice to have a business degree and a medical degree, or have a clinical degree and also a medical or a business degree. Putting those things together means that you can provide services in a way that wraps around and really take into account all those measures. So if you're thinking about your MBA, I had a really good experience. If you ever want to talk about it, it went well. I am currently the Senior Vice President for Volunteers of America. I'm over our integrated services, so that means I oversee everything medical and everything behavioral health for Ohio and Indiana. If you've seen me before, I used to be the director for the Choice program at Community Health Network, but switched to VOA in September. There's a lot of cool things coming this year, so I'm really excited next time that this conference rolls around to talk to you guys about the housing models that we have going right now. I could give you a whole talk about the apartments that we're building in the Indianapolis region for that, but we'll stay on a little bit of focus here today. Guys, good conversation is more important than the slideshow. That's always my rule. Like, I have 4 kids. I'm well used to being interrupted, so please raise your hand, speak out. I'm here to talk. Like, we've got our half hour together, and it can be interesting or it can be boring, and it's usually more interesting when people have a question. So don't wait to the end if you've got a question. I want to hear it. Raise your hand. If I don't see you, wave at me. It is a little bright, so wave at me, and we'll have a discussion. Again, interrupt. I am well used to it. It doesn't even faze me, right? 4 kids between the ages of 27 and 13, so literally had a kid in elementary school for 21 consecutive years. So well used to being interrupted. And if we go on a tangent, then so be it. Oftentimes when a tangent happens, I find that it's better than what was going to happen. So I'm here for that journey. All right, guys, so big thing I want to talk to you about today is something that I'm seeing a lot about, and that's I call it no fighting in the lifeboat. And literally I want you to think about that from the concept of, in our recovery journey, there hopefully are many different resources that come together to build the resilience of the person seeking recovery, okay? It usually is not just one resource. It's usually a multiple layer of resources that come in at different points or some at the same time that layer to build a resilience, that make a braid that is stronger than just one strand alone. And I see a lot of infighting amongst these providers. And that's really odd to me because we're all in the same lifeboat, right? We're all trying to help people seek recovery. But I'll see these like absolute death stance about like it can only be done this one way. And if you don't do recovery the way that I did it or the way I think you should do it, you're doing it wrong. Okay? Like, whew, smooth your hair, deep breath, like get right. Because that's just not reality-based. And so I definitely want to make sure we talk about that. The big thing, guys, is I want to see what we can come up with as far as building these multidisciplinary teams that enhance and not hinder recovery, that don't trip over each other. I had a client one time call me from her pediatrician's office just absolutely sobbing because her pediatrician told her she needed to immediately stop taking any form of MOUD or MAT, which specifically she was taking a medication called Suboxone. She's breastfeeding her infant. It's completely allowed to breastfeed an infant when you're on that medication, okay? And her pediatrician told her, you need to cold turkey stop taking this medication immediately today. So anybody have any experience of a loved one or a client or a patient, any experience with someone who was taking MOUD, taking Suboxone as a medication to help treat their substance use disorder? Okay, so does anybody want to say what would happen if you just immediately had a 3-day-old infant at home that you're breastfeeding and you immediately stop taking your Suboxone? Anybody want to say what you think would happen? Would it go good? Like, you give me a thumbs up or a thumbs down? Okay, yeah, duh, right? And so those duh moments are where you have to say, like, what was the pediatrician's thought process? And even I called the ped thinking, like, there's a misunderstanding. Surely there's a misunderstanding. And the pediatrician's like, the baby's going to detox from this medicine if she stops taking it. And she shouldn't breastfeed anyway, because what if she starts using again? Right? Like, and I'm like, okay, we are never recommending you, ever. You just went on our like list of people that we'll tell people not to go to you. Because that is horrible advice, and it's a horrible thought process. I had an OBGYN that I used to work with who was not directly affiliated with my former program, the Choice program. And this OBGYN made a comment to me about, why do we treat Hep C? It's so expensive, and they are just going to reinfect themselves. What? Like, literally, I have a joke where I'll say, like, my left eye just started twitching, right? Because it was like, whoa, what you just said made me lose control of my face. Like, I can't, wow. I heard it described as it was a struggle to remain professional in that conversation, right? And sometimes that is a real struggle. But I heard that. I said that was wrong, and we treat Hep C regardless, right? There's so much better treatment for Hep C now than there was back then, but specifically, we still treat people's medical issues regardless of that. I've also heard that used in correlation with cardiac valve replacement. So sometimes people who struggle with IV substance use will have some heart valve issues that they'll need a replacement valve. And I've heard people make conversation like, well, how long has she been sober? Like, that's the correlation of, are we going to do this valve replacement or not? Like, are you worth it kind of conversation? And that is a lot of stigma, right? So we see these different kind of healthcare. I see those examples in healthcare, but I see them in all fields. I have had some really good go-rounds. I love 12-step, okay? If it works for you, please use 12-step. There's people in this room who have found recovery via 12-step, and I love that for you. And please keep doing that, and yay, 12-step. But that's not everybody's journey to recovery, right? And so 12-step's not the only way. It's one of the awesome ways that exist. So for those that 12-step wasn't the right phase for them, then another journey is going to make more sense. You shouldn't be shamed because that was not the step that made sense for you. Okay, so we're talking about I want to talk specifically about who's in this lifeboat for a second. So medical providers. So who in this room would identify themselves as a medical provider? Nurse practitioner, doctor, whatever, great. And then peer recovery coaches, or I've heard a lot of different phrases besides coach. I hear support, there's all these different things, but who would consider themselves to be a peer? Awesome, great, some good peers, love peers. And then we have the behavioral health specialists. Anybody who considers themselves, I work in the field of behavioral health, is what you would say. And the peers are kind of both those things, right? Anybody specifically a case manager? Yes, case managers are like the secret weapon in all the things, right? And then anybody faith-based who would say that they're a faith-based leader, or like just not somebody who would fall into this other aspects. And then, of course, the social services who wouldn't, some social services people don't necessarily call themselves behavioral health. It's an interesting, right? There's a lot of different factors there. And then there's just kind of the other category. That's all good. All these people can work together for the same outcome goal, which is recovery. And every client is going to need a different combo of this. I want to talk about silos versus bridges. Has anybody ever heard the concept of the silo of care? Anybody ever hear that before? So a silo of care would mean like a grain silo, right? It sits there in its own little circle with its own little roof on it, and the grain in that silo doesn't touch any of the other silos, which would mean like the people who are working in this one program, they don't talk to other programs. They don't collaborate with other programs. They don't have relationships built with other programs. They might have a really good program going, but they're not collaborating with any of them around them. So they have a silo of care. And I see this a lot in the medical community. Especially before we had really good systems that talk to each other, you would see like a cardiologist who never speaks to the OBGYN, who never speaks to the behavioral health people. They had zero communication amongst each other. That Epic, specifically the system Epic, did a lot, and all these EMRs did a lot to really help. The electronic medical records did a lot to help the communication be better. You still got to read the information, right? So like working in an OBGYN clinic, we could have somebody come in. If I didn't read their notes from other providers, I was still working in a silo. I had the information in front of me. I just didn't have time or didn't have the inclination to use it if I wanted to. I read it because that's where you learn a lot about how to help people in a more holistic way. The concept of bridges of care, that means that you've got relationships built with other places. You want those relationships ideally before you need them. So if you're working in this one program and you're doing this one thing, you want to know who's the OBGYN in the community that I know takes good care of these clients? Who is the cardiologist that I know is going to be a true resource to these patients? What office is going to treat them nice when they walk in the door? If we don't do medication for opiate use disorder like Suboxone in this clinic, who does and who's going to be nice to them about it? Who's going to take insurance? Who's the shady ones? Who's the pediatrician that told her to stop doing that? No bridge to you, right? That bridge gets blown up. But we'll make another bridge to another pediatrician who is going to give them good advice. And you need those relationships before you've got a client sitting in front of you. I always use the example of the client who came in to see you for their appointment, and their cat's in the car, it's February, they have no more gas, and they're 39 weeks pregnant, and this is their first access to care. That is not the moment to build all those relationships. You need them ahead of time. As many of those as you can anticipate. But in the care of clients who struggle with substance use disorder, every client is going to bring something new. You're going to need to build a new relationship almost every day. And sometimes the relationship you built, the person that it was built with goes away. It's a lot of work to build and maintain relationships. It's well worth it. And when those relationships are no longer working, you find another resource for that. What do we do with the cat in February? Client needs to come in to detox. She's literally got a cat in February in her car in the parking lot and no more gas. And nobody in her own circle that she trusts with the cat, who is her sober partner, for real. So that's her resource, that's her connection to this world right now, is that cat. And she says, nothing better happen to that cat or I'm done. And I'm like, all right, the cat is my focus today. So can we take the cat to the pound? Why can't you take the cat to the pound? You might never get it back, right? She wants the cat back. She needs it back. It's her sober partner. Okay, guess what? There's foster care for pets. Did anybody know that? I didn't know that till then. I had to learn that resource that day, right? But I wish I'd known that already, because those resources are phenomenal. And every community has different resources you plug into. That's when it gets tricky. Does anybody work in a program that's like statewide, where you're helping clients throughout the whole state? It gets really tricky to figure out where to send them. I don't know who's in Seymour, Indiana, right? Except John Cougar Mellencamp. That's all I know about Seymour, right? And the Tasty Freeze, which was also from a John Cougar Mellencamp song. John Cougar Mellencamp. But, right? Who grew up in Seymour? Ask Google. Damn it. All right. Oh, anyway. Okay. See, I don't know the resources, but nonetheless, those are the communities that sometimes it gets really tricky, especially when you run into communities that have no resources. So when I'm in Indianapolis trying to help a client, I've got way more resources than when we get to Winchester, Indiana, where there's just less opportunity. There's less things to send them to. You know, and then you get into the nuances of specific programs. Is anybody here from Nurse Family Partnership or ever worked for them or have? I love that program so much. But in most regions, it's only for first-time moms. And that's where we say, okay, this client has never parented a child before, but this is the first child they plan to parent. Does it, you know, you got to learn those nuances, right, of the different programs. It's well worth it to at least have a small bucket of those resources that you know it well enough to reach out to them and say, what do we do with the cat? And somebody, hopefully one of your other resources knows what to do. Now you know what to do. But those are such, part of what makes caring for these clients daily interesting is that there's always something different that you need to learn, that you need to grow, that you need to rise to. And trying to get them to fit in your silo versus building bridges that help them transport is a way better strategy on the bridges. The silos just lead to fragmented care. And the one that really gets to me is the fighting amongst the silos. We're going to sit in our silo and we hate that group over there. Okay, calm down. Like, let's figure out, okay, if they're not doing things the way that you think it should be done, then find one who is. If you're the only one you think is doing it right and nobody else is doing it right, then you need to think about, why did our strategy not align with anybody else's strategy? And then you might want to look up some data, because there might be a chance that you're the problem. But I'm just, I'm just throwing that on out there. All right. Oh, I said, why is there, look at my cute little animation I threw on there. Why don't we see a ton of this? It's expensive to have all these things internal to one program. It's very rare that you're going to come across a program that has all of this embedded within that one program. Every now and then you'll see a place that's really covered a lot of bases. I have a friend who helped, Devin Jones, who runs HealthLink, and they have like I always say they have all the cool toys, right? Like they've got dental right there, they've got lab, they've got all these cool things right there on site. That's phenomenal. But it's expensive to do that, and many places don't have it laid out like that. So build those relationships with people who are doing that. The consequences of infighting. Again, let's do a thumbs up, thumbs down. Who thinks that infighting is good for a program? Give me a thumbs up if you think it's good and a thumbs down if you think it's bad. Right. The infighting is horrible to watch, and you really can see some pretty decent disagreements that can really affect these clients' outcomes. So, of course, you see power struggles within the recovery community, rigid, one-size-fits-all models. We used to get asked all the time to do an algorithm of what it was like to do client care, okay? So like, if client walks in the door and their drug screen is positive for this, what do you do next? And I was like, whatever is right for that client. Because it's really hard to answer that question. Some clients are gonna need that moment where you sit down with them and say, listen, you're 38 weeks pregnant. You're actively struggling with fentanyl use disorder. I have really serious concerns about what's gonna happen with DCS. Let's talk about, like, we got to have that hard conversation. What if client's 12 weeks pregnant? We got a little more time to go a little slower with this conversation, right? And so I know that we need to be very serious about hard truths spoken out loud. We have to say hard things to clients. You're 38 weeks pregnant, you're actively struggling with fentanyl use disorder. We got to talk about what this could look like for DCS. Do you want to continue to parent your child? What would you like that to look like? Right? And if they tell you, well, I'm going to get out of here after I have my baby and I'm going to move into a 3-bedroom, 2-bath house with a fenced-in yard that you're going to find for me, and I'm just going to miraculously be sober one day. Okay, let's talk about what that could look like from a reality perspective, right? What can we do to make that make more sense? How do we get you to that point? And those hard conversations are really hard, but it's not every client that needs that tough love right at that moment. You really have to have an instinct for how to care for these clients. And if you don't yet have that instinct or feel comfortable with that, then you need to pair with somebody who does, who you can be mentored by on how to do it. You can learn how to do that, but you need somebody who's, I say, like, has the sixth sense of what needs to happen at that moment. And you know those people. I mean, who knows somebody like that who can just seem to know? They walk in the room, they have this initial conversation, and they're usually pretty right about what needs to happen next. Does anybody know that kind of a provider? They're cool to be around. They're like psychic. So utilize those skills to learn what they're doing with that, if you don't have that yet. And if you are one of those people, then keep doing that and bring in people who want to be mentored under your wing. I see unlicensed individuals giving medical advice a lot. A lot. Has anybody seen that ever? Unlicensed medical professionals who will tell people you can't be. I've seen problem-solving courts that tell clients that they can't be on medications to treat, life-saving medications to treat substance use disorder. I'm not a lawyer, so I don't give legal advice, right? But I find it interesting when lawyers give medical advice, right? I love lawyers. My mom's a lawyer. Like, lawyers are good in many ways, but like not medical, right? And so when I see drug courts mandate what treatment a client can have that isn't based on data that relates to medical, I find that very interesting. It's an interesting equation. So you're telling them the only option for their recovery is Vivitrol. What if it's not? What if there's other options that would make a total difference in their lives? And it's going to be different for each person. Detox centers with complex referral processes. We have to meet clients, and I know we say this all the time, right? It's such a cliche. We have to meet clients where they're at. Okay, you hear that all the time. But for real, we need to be open when clients need to come in. So if we are talking about specifically pregnant women with substance use disorders, was my previous medical specialty, but all people with substance use disorders is life-saving medicine. People are dying like crazy from opiate overdoses. You know what's interesting about that? Every single one of those opiate overdoses was a preventable death. If somebody had been on site with them and been able to give them a dose of Narcan, and if you're comfortable and if you carry Narcan on a regular basis, you don't have to raise your hand, it's not mandatory. But who in this room carries Narcan with them? So the rule in my house is if you hit puberty, you carry Narcan, right? If you're old enough for puberty, I don't need the dates, you're old enough to carry Narcan. And so that now is everybody in my house. I'm sure my 13-year-old will be really glad I told you that. But that aspect of carrying Narcan and explaining how to give it, because my 21-year-old, bless her heart, is adorable, but like she's like, okay, so do you give it like flow days, like once and then, no, honey, just, and then I tell them when you give, has anyone ever seen a person get Narcan? Right. Do they hug you? No. Because they wake up usually very afraid or very startled, okay? So if you ever are in a situation where you're gonna give somebody a dose of Narcan, don't, you know how, is anybody CPR trained? In CPR, they tell you to be like right in the person's face, right? Like, are you okay? Are you okay? And then you're like, ooh, you get the AED, you call 911, right? Like, have I taken 500 CPR classes? Yes, I have. And if you are going to give a client Narcan, a person, Narcan, and please give it to them and then take 2 steps backwards, okay? They used to call that, in the ER, I worked in the Narcan 2-step. And they would say, if you want to keep your face in the position it's in, take 2 steps away, because they're going to need a minute when they wake up. So you want to be out of the swinging range because they may be very startled and you may get hit in the face. They used to say, Brooke, if you like your nose, you're going to want to take 2 steps back because they're going to hit you. My nose, you know, like, but yes, you just know that, please, with Narcan. Please don't, if you do give a dose of Narcan, please give Narcan. And also, if you give Narcan to somebody who doesn't need it, nothing will happen. And then you know you should start CPR. So I'm going to get in a fight one day with all the CPR training about, I think you should give Narcan first and then start CPR. Why is Narcan not in the AED kit? Thank you so much. Stigma. But anyway, okay. So detox centers with complex referral processes, we should be able to obtain services for clients quickly. Clients should be able to obtain them when they're ready. If that's 2 a.m. on a Saturday, then so be it. And so we in this community need to make sure that we're ready to rise to that challenge of providing those services 24/7. Lack of collaboration between multidisciplinary teams, okay? You got your therapist here, your OB here, your cardiologist here, and the peer recovery services that are helping you here, and none of them are communicating with each other. Those outcomes are not going to be as good as if those teams could collaborate with each other. And sometimes the client is not in a phase where they're ready to be the communicator. Trauma-informed care tells us that multiple new faces is a trigger for trauma response. And so sometimes when you tell somebody, well, go to the cardiologist, that is a very high anxiety moment for them. And sometimes they just won't go, regardless of if they need the life-saving services of a cardiologist, because just going through the process of checking in, going through their medical history, explaining the whole situation, is just more than they can handle at that moment. So then you see these really great programs where they like go with them, right? These home health visiting services that will be their nurse who knows their history and goes with them to these appointments and says like, Don't forget to tell them that you're taking the blood thinner that your OBGYN described. You know, like those little moments make a big difference in that engagement with care. So the power of teamwork itself. You get better engagement with higher retention into treatment with clients who are in integrated services, who really have multidisciplinary providers. And keep in mind, too, what have we said? The client decides. Recovery is individual. So if they're like, listen, I am never going to work with a therapist, fine. You can't say we have to work with a therapist. You'll never get better. You'll never stay sober if you don't work with a therapist. That's not true. That might be exactly what they need, is to not work with a therapist. Okay, fine. I love therapists. I think everybody could use one. But if that's something they don't want to do, forcing them into that care can actually have way bigger negative impacts than positive impacts. Fewer gaps in care. So people who are in a integrated service have lower relapse rates. That's the whole ticket, right? Lower relapse rates means less risk of dying. So we love lower relapse rates every time. Improved coordination of care. So they have they have lower costs, and they are better utilizers of healthcare systems. And I mean healthcare in all aspects, not just medical care. So breaking down these barriers, really looking for that lack of communication amongst these different disciplines, and how stigma within the healthcare and behavioral health teams make huge impacts on these clients. I hope you know that already. Like, stigma has such a huge impact. We could do a whole talk just about stigma. But really the discussion today is, how do we get these groups to work together? Solutions: regular interdisciplinary team meetings. You do not, if you have a release of information from the client, if the client says it's cool, you can talk to other providers, especially with the client. That happened to me once with a client who was working with DCS, and all her providers came together in one room with DCS with her and went through the whole process of how well she'd been doing and what was happening. And it made a huge difference to how DCS engaged with her and her recovery journey going forward from there. Shared electronic health records make a big difference, and open dialogue about patients' needs. So guys, here's some of the red flags of recovery programs. When you get the one-size-fits-all approach, they have to do it our way or they have to get out. That's a red flag. Lack of multidisciplinary teams. So programs that only have one type of professional in them and they do not collaborate with any other teams, that is another concern. High discharge rates from programming, especially rapid discharges with no safety nets, no safety plans. People thrown out onto the street without any aspects of what happens next, those are also very concerning. Places that are not well known or have poor reputations, minimal aftercare services, or overemphasis on financial gain. Many places now take Medicaid, and so that changes a lot in the healthcare community, or in the recovery programming community. But it really need to be careful when you get a place that says that it's, I called somewhere the other day, and it was, or one of the team members did, and they called me to tell me it was $90,000 for a 28-day stay. In Indiana. It wasn't even like on a beach somewhere. Like, it was $90,000. I'm like, but there's a cash discount. So if you didn't finance it because they had internal financing, do you see that? What? You're going to make interest off us trying to find a place to send our child, you know, like, and you're saying 90,000 and we'll take them today? That's pretty scary, right? And then you get negative or unsupportive staff. Teams can get in a rut. That happens sometimes. But getting out of that rut, being focused on that, and getting back on track because a positive mental attitude makes a big difference. So you've heard this poem, I'm sure. You give a man a fish, and you teach him, or you feed him for a day, you teach him to fish, you feed him for life, right? It's a really nice concept, right? And I'll hear people say, you can't enable them, you can't enable them. Okay, but if you're starving to death, we got to feed you first, and then we can teach you to fish. You cannot learn how to fish if you're sitting there starving to death the whole time. We've got to feed you first, then we'll teach you how to fish. We got to get people safe, we got to get them into life-saving measures, and then we can teach them things like, you got to be on time to your doctor's appointment or your doctors aren't going to see you. If you're 2 days sober from fentanyl, that is not the moment for a hard lesson learned, right? That's when we say, okay, listen, you're half an hour late, but here's, like, we're going to work on this, we'll figure this out, but let's, like, most providers aren't going to see you half an hour late, and so this is one of the skills we're going to work on, right? Not 2 days sober. You got to feed them first. You got to keep them safe first. Okay, so what can we do today? can't read my own writing. We have to commit to that collaboration. We have to commit to building relationships, even if it's just a few. Next week, just reach out to like 2 or 3 places that you want to get to know better. Tuck that in your little own Excel spreadsheet. Get on 211 and look through their resources. They are updated all the time. You don't need to build your own. Like, there are people who are like, no, I have my own, and I don't use 211. I keep my own sheet. Okay, that's good, but also remember those things get outdated if you're not constantly maintaining them, and somebody else already did the homework. 211 already has the info. So you don't have to create your own entire system of how to know these resources. You can use the resources that are already present or utilize them to gain connection to them. Be a silo breaker, not a silo maker. And then also keep that focus on the client. Every client is individual. Every client is unique. Every person in this room has a complex life. People are complex by their nature. So acknowledge that, be conscious of that, really guard against that one-size-fits-all, only my way or the highway approach. So guys, this is my contact. Schaefer is spelled a little uniquely for some people, which is why it is highlighted. So I often get people who are like, I try to email you, and Schaefer, it came with a great man, but it is spelled a little bit different. So just, you know. And then VOA also is OHIN. So Ohio, Indiana, another point where people are like, I emailed voa.org. I'm like, no, that's why you didn't get me. So that's my contact. That's my personal cell phone number. If you ever need me, please reach out. Always glad to help. And then these are some books that I greatly enjoy. I know I'm at time, so I won't go too deeply into these. I'll tell you, I listened to all of these on Audible. If you saw, did you guys see Wendy No speak earlier today? Or was it yesterday that she spoke? She introduced me to this book, The Many Lives of Mama Love. I don't know if she talked about it in her presentation, but she introduced it to me, and I love that book. That is a really good one that she just introduced to me. Again, I've listened to all of these on Audible except The Heroin Diaries by Nikki Sixx, who, yes, is the bass player for Motley Crue and the songwriter for Motley Crue, by the way. And his is a journal where he has like sketches. He wrote this when he was in active use phase of a heroin use disorder, and he has like journal entries and drawings and pictures. That one needs to be read. Like, you need to hold that book in your hands because you need the pictures that go with it. It's not just his words, it's also his pictures and drawings and sketches and things that he talks about in that book. So I think that one's pretty important in the scheme of recovery. All right, guys, so that's it for me. I'll go back, I'll leave this up so you can take a picture of it if any of those books are ones you want to read. You've got my contact. And is there any questions before we close? Yeah. I think that the communication with the provider about that makes a big difference because the provider is the one who gets the script bounced back to them. And you can tell by the pharmacies that are sending them back to you, like who's a pain and who isn't. Like, I know that Meyer and Anderson is awesome. Like, they don't give my clients any grief, but I know that PharmaSave and Anderson is not functioning in that same level, right? And so you really learn who those places are, but then that's yours to communicate to the team. We're never going to tell a client, of course, you can only use this one pharmacy. But if they come to us and say, this pharmacist is being so mean to me every time I pick up my scripts, okay, well, you know what? We've had good luck with this place. Do you want to try them? No, I got to go to that place. All right, we'll send it there. But maybe there's another pharmacy you want to try. So I've had pharmacists I've never met face-to-face that I really enjoy working with because my clients get treated well in their pharmacy. And I feel like pharmacists set the pace of how the whole pharmacy runs. And so there is some of that. There's also pharmacies that we have said we do not send scripts to this place at all because of how they treat our clients, unless the client absolutely says it has to be that one. Yep. Yeah. dude. Yeah, simmer down. Yeah, yeah. I had a pharmacist argue with me once about prescribing to a pregnant woman, Subutex to a pregnant woman, and I'm like, yeah. He's like, you know she's pregnant. I'm like, I do. Her baby just kicked me. Like, I literally do that. Thank you so much for that information. You know. No, some of them are wonderful. Absolutely. Yeah. Yes. Any other questions? Anybody? All right, well, thank you guys. Appreciate your time.
All right, is Dr. Turner here? Paging Dr. Turner. Okay. Oh, there she is. All right, so we are just heading up for our final speaker, and we'll get her started, and we will wrap up our day today, maybe a little bit early for you guys. All right, so we are here. Our last speaker of the day is Dr. Sarah Turner. Who knows Dr. Sarah Turner by a round of applause? Thank you. For all of our out-of-towners, Dr. Turner is probably one of the most well-known, well-respected doctors in our community. So we are very pleased to have her here. And a dear friend of mine, she receives random late-night texts from my questions about WebMD. I apologize. But anyway, so Dr. Turner's here, and we are just so honored to have her close out our conference.
Thank you. Okay, so I'm going to talk about language, and I had like grand aspirations of dressing up like Buzz Lightyear, but it didn't come to fruition, so I apologize. I'm going to start by telling you a story about a little girl. She had a very normal childhood, no abuse, a little bit of bullying. I was definitely overweight when I was younger, not in any of these pictures, but I couldn't get my dad to send me any in time from where I was. And I think that's where a lot of my negative self-talk started, was in like middle school, elementary, through bullying. But overall, a very happy childhood. Just, I do remember a lot of it being somewhat negative in my internal monologue. So. Our words are super impactful. What we say to ourselves can lead to all sorts of different changes in our self-talk. Our self-talk is our inner dialogue. It's what goes on in our head. It's how we sort of frame our day. This is happening all the time, and most people will have a mix of positive and negative. At times in your life, you might have one more dominating than the other, but both are very normal, both are very healthy. So sometimes it's not as healthy, and our brain can tell us stuff that isn't necessarily the best things to tell us. Our words to each other are super impactful. Sometimes, you know, the most tiny little interaction with someone can either absolutely make or break your day. And so it's really important that we're super mindful of stuff like that, and that we control how we react to these situations, because this is where we can help change other people's self-talk. So. The origins of self-talk, there are some theories that it's coming from potentially other old experiences that we've had in the past, interactions we've had in the past, as well as some of the other places in our lives, genetics and stuff like that. But it's generally our subconscious is where the self-talk really comes from. That is a mix of genetics and experience, and it's not something that we have control over. We can't just like control the self-talk, but we can rationalize and react to it. So that's where we want to kind of focus a lot of our energies, is trying to figure out how we are going to react to it. So that little girl grew up, and she fell in love when she was in medical school with a lovely guy. And I very much remember being so happy. I would literally be doing the dishes and crying because I didn't think it was real. And I was literally waiting for him to leave me, waiting for him to wake up and realize that I wasn't good enough and that I wasn't deserving enough for whatever reason. I don't know why I felt like this was the thing I had to tell myself. And I've always been an incredibly confident person and carried myself with a lot of good self-worth. But I was, any day now, he's going to figure out that this is a sham and he's running away. So I married him as quickly as I could in Manhattan City Hall. We took a day off of work. I needed a green card. And yeah, we're still very happily married, so thankfully he didn't wake up yet. But yeah, still, the negative self-talk continued quite a lot. Negative self-talk, AKA stinking thinking. So it can come from a place when we get too much on the negative side, a place of shame. And there's a lot of places that we can get shame from. We can get shame from ourselves, internal shame. We can get shame from our peers that we either know is coming from them, or we're assuming is coming from them, we're projecting it on them. Or we can get it from government agencies, the media, whether they mean to be giving it or not. Again, we can be projecting that. But those are where a lot of our shames can come from. And the more shame we feel, the more negative self-talk we go, and it's just sort of an endless cycle. At times when it gets to be too much, we can start getting into a place where we feel no self-worth, have very little self-forgiveness for the littlest things. I'm sure we've all had those moments where you like blow up on yourself for the stupidest little thing that you've done, and it's an overreaction, but this is where a lot of this can come from. We put unrealistic expectations on ourselves all the time. Other people put unrealistic expectations on us. And then there's this whole idea that we should be able to do everything well. And so that's a very common unrealistic expectation. So that's where, again, a lot of this sort of perpetuates and grows and perpetuates and grows. In the world of addiction plus negative self-talk, those two work really, really well together to keep you from getting into recovery and staying into recovery. So in the world of addiction, we really, really want to start focusing on people's negative self-talk and their inner dialogue and trying to focus how they're talking to themselves consciously and subconsciously, so that that's the sort of stuff that's going to lift them up and give them the belief that they can get into recovery. So. There's a lot of different associations of recurrent negative self-talk with pregnancy. We can see increased depression and anxiety. We can see increased stress and inflammation in the body in general. And then we see decreased engagement in health-promoting behaviors, which would include stuff like breastfeeding, counseling, eating healthy, exercising, sleeping well, all those sorts of things. So when we have people who are pregnant, that's a big time for a lot of people to feel guilt for one thing or another. And again, as we're interacting with these women, this is where we can start kind of talking about that. Examples of the stinking thinking. There's several different types. So all or nothing thinking, this is when we're seeing things very all or nothing, very extreme ends of the spectrum. I always fail. I can't ever do anything right. We can catastrophize, and this is where we're always ready for the worst case scenario. We're expecting the worst case scenario, and although at times that can seem protective, if you're ready for the worst case scenario, then when it's not quite that bad, you're ready for it. It can actually take you into really deep, dark cycles of doom feeling. And then you fear making even the smallest mistake because you feel like it's just going to end in disaster. Mind reading. Mind reading is when we assume that we know what other people think. And so this is where we put a lot of our projections of our feelings about ourselves and shame and self-worth onto other people. They must think I'm so stupid. They must think I'm such an idiot. So we do that to ourselves all the time. Self-labeling. This is where we attach negative labels to ourselves based on prior mistakes, shortcomings, things that we think we should be doing. I'm a failure, I'm worthless, I'm not a good mom, I'm the worst partner, what is wrong with me? We'll discount the positives. So we really do a great job of focusing on all our negative aspects, but it's really hard to look at positive stuff. So downplaying our accomplishments and rather focusing on the one little thing that went wrong rather than the 5 things that went right. Overgeneralization. So this is when we're making very, very big conclusions from something that should be relatively small. So if you were to ask someone on a date and they rejected you, clearly I'm unlovable and no one's ever going to want to be with me ever again. So it just kind of takes things to extremes again. Personalization, that's when we blame ourselves for events that we really have absolutely nothing to do with. So we do that a lot. And then the last one would be should statements. So should, must, ought to, I should go home and spend all the night with my kids, even though I have 400 things to do. I should make sure that I'm staying up all night to finish my PowerPoint presentation because it was due today. So we can lead down these paths with a lot of guilt and frustration, and that just generally doesn't get us anywhere productive. So those are all the most common types of negative self-talk. These are just some examples of ways that you can take negative self-talk and sort of flip it a little bit. It doesn't take a lot to look at things in just a tiny bit of a different light, but you can see it's a very different spin on the same sort of a thing. I've never done it before. I don't know how to do it. I definitely said that one before, but we should look at it. This is a chance to learn. Not everybody knows how to do everything. You had to learn things when you were little. We didn't fight it when we were little the same way that we might fight it now. But there's lots of different ways to kind of take a spin on things and try and look at it a little more positively. And that the more we do that, the more we actually promote positive self-talk. And the more we promote positive self-talk, the more we can actually decrease risks of depression, anxiety, all these sorts of things. The ultimate positive self-talk was the little engine that could, and we all know that one. So I think I can, I knew I could. So, all right, so that little girl and her husband grew up and got pregnant with baby number 1. I remember taking that picture and I felt disgusting. And I look at him like, that's such a cute picture. I felt so gross. I felt so huge and swollen and fat, and I couldn't bend over and tie my shoes. I had my baby, and he was perfect and beautiful, and I immediately had a lot of struggles with breastfeeding, which was the beginning of a very severe postpartum depression. Like it happened literally within the first 24 hours. And so that, of course, what is wrong with me? Why can't I feed my baby? What kind of a mother if I am if I can't give my baby food? I definitely didn't want to do formula because it was evil. And I shouldn't. I went in with very, very unrealistic expectations for myself. And it was complete self-sabotage. That was definitely at the height of my postpartum depression, so much so that I don't remember taking that picture at all. I looked pretty happy, but I was not at all happy. I hid it very well. Even there, definitely not happy there. That was, while I was off between residency and fellowship for 4 months, and I hated it. I am not a stay-at-home person at all. I felt like I completely lost myself. I could not wait to get back to work, and I felt so guilty about that. I could not wait to leave my son. What kind of a mom am I if I'm going to leave my son like that? So, I definitely didn't like that photo shoot either. I felt very uncomfortable in my skin. Even though that body made that beautiful baby and fed that beautiful baby, I couldn't appreciate those small little wins. So, and once I was at work, I had a lot of issues with my son in that my husband was the primary parent, and he would reject me when I came home. And I very much turned into a toddler and would have little temper tantrums and get angry at him back, and he's like a year old. And it was a really, really hard time in my life, and it was dominated by pure negative self-talk all the time, very depressed. So, what makes a bad mom? I mean, there's definitely some good definitions of like solid bad parenting. Consistently and intentionally neglecting your child, consistently and intentionally abusing your child, not supporting or encouraging your child ever, constantly criticizing and insulting your child, manipulating your child, giving them a lack of boundaries or discipline, allowing unsafe or inappropriate behavior, not being involved in your child's life at all. So those are all some pretty clear, like I would say, people who do that consistently on purpose would probably be characterized as a bad mom. If you ever need some frame of reference, the Quokkas throw their babies at predators to run away. So you're never going to be a worse parent than that, I hope. But what feels like being a bad mom? This is where I feel like a lot of us live. We feel like we are a bad mom because we didn't like pregnancy. We hated pregnancy. It was miserable. We were uncomfortable. We didn't like the newborn stage, which is it's beautiful and they're so cute, but it can be miserable and isolating and lonely. We disliked the stay-at-home life. I hated it. I absolutely hated being home because I was so bored, and I'm sitting at home with someone who can't talk to me, and I'm a very social person, so I didn't like that. Putting your needs above your child's. We all struggle with that. Ever putting yourself above your child's needs. I need to exercise. Oh, I can't do that because I'm not going to be able to be around my kid. I need to make sure I go to the store. Well, I have to be home with my kids, so I'll go after they're in bed when I should also be in bed. I had a really good Peloton ride years ago, and she said it just so beautifully. She said, what you're doing here on the bike is what makes you a better parent, a better friend, a better partner. This is what you need to be able to take care of other people. And that's, I think, once I could actually get that through my head, I feel like that was actually a massive turn for me, to realize that my needs weren't just my needs. Taking care of myself was taking care of my family and my friends and my kid and everybody else. So, but I think this is where so many women struggle. Disliking parts of parenting. Who here has not disliked even 1 minute of parenting? Ever. Like everybody, right? And I bring this up with patients all the time. I tell them, I'm like, there are definitely times I don't want to be a mom. I wish I wasn't a mom. That has absolutely nothing to do with my feelings towards my child, or my children now. Our feelings towards our kids and our feelings towards parenting are two mutually exclusive things. We can love our children and hate parenting sometimes, and it's not because of our kids. It's like, I want to sleep in, or I want to go on a trip on a whim and not have to worry about keeping tiny humans alive. Yeah, I still love them, but I can still not like all of the parenting stuff. But again, we struggle to separate those things. And then we feel shame and guilt and like bad parents. Our child getting in trouble at school or being a bully, at some point that has to be our fault. We didn't do something, we forgot to teach them something. Our child failing in school, what did we forget to teach them again? And then going back to work. I think a lot of people struggle with going back to work, and then if you don't struggle with going back to work, you struggle with the fact that you're not struggling, and that you should feel guilty, and you should hate going back to work. You should want to be with your kid all the time. So, and I think there's a lot of like, who's better? Is it the person who's going to work or the person who's staying home? There's no answer. Everybody is individualized, and some people are way better stay-at-home parents, and some people are way better work parents. But whatever's fostering you and your mental health is what you need to do. What makes a good mom? I mean, who gets to decide that, for starters? I don't know who gets to decide that. In general, we pick social norms. There was a study that was done that looked at like over 1,000 different studies and sort of did a meta-analysis, and they came up with 5 things that you don't have to have all 5, but these are the 5 things that are generally repeated in all of these studies in terms of being a good mom. So being present, and whether that's like physically present or I'm present enough to make sure that you're taken care of by somebody, you're getting the care you need, whether it's from me or a nanny or your other parent or your grandparents or a daycare, you're getting the best care. You're fostering their physical and cognitive development, so we're making sure that they're getting all the fostering they need in terms of all their physical skills, their speech, all that sort of stuff. We're helping them be ready to succeed in life. We're making sure we incorporate work into motherhood, whether that's work at home or work outside the home. When moms show that they're working, it actually fosters more independent children. And there's lots of studies that show that kids, when they learn the ethics of good work, but they learn to depend on themselves a little bit, which is not a bad thing. And then being in control of our body, being in control of our kid, being in control of our situation, our mothering performance, all that sort of stuff. Having control and feeling like we're in control definitely helps us be good moms. And then being happy, being content. And it doesn't have to be happy all the time. We're just like, I'm happy with where I'm at in life. I'm miserable sometimes, but that's okay. You're going to be miserable sometimes. But in general, I'm happy with where I'm at. So you could have one of those 5 things, just one. And it doesn't even have to be all the time. And that would make you a good mom. And I feel like if we could look at that, we would all feel so much better about ourselves because we expect we need all of those and then some. And that's, I think, where we sort of self-destruct. The transition to motherhood is a massive one, and I watch people do it every day. I had 3 people do it in the last 24 hours. And I try to prepare people so much because nobody ever prepared me for any of this stuff. And I think there's this ideology that it's supposed to be natural. It's supposed to be normal. You're going to birth your baby, and it's going to be beautiful, and you put your baby to the breast, and angels sing, and rainbows and puppy dogs come out of the corner. And no, that is generally not what happens. And then when we struggle, oh, what are we doing wrong? How are we failing our kid? How are we failing ourselves? What have we failed at here? When in general, this is stuff we've never learned before. If it wasn't motherhood and it was like learning how to play the guitar, we wouldn't be as terrible to ourselves and talk the way we do to ourselves. But trying to prepare people for motherhood, and I think that's what we can do in a lot of prenatal care is, hey, guess what? It's going to suck. It's going to be so hard, and we have no frame of reference on how hard it is. And I think the number of women who go through postpartum depression but don't realize for 6 months to a year is massive because we all know it's going to suck, but we just don't know how much. And get to a year out and be like, well, I'm pretty sure it wasn't supposed to suck that much. And I hear that story all the time, and that's why I try so hard to get on top of them. I try and screen them, and are you okay? Is this all right? It's okay if it sucks. It's okay if you don't like this. Because I think that is also really hard. When it's really hard and you don't like it and you think, well, I wanted this pregnancy. I feel guilty because other people can't have babies and I have my baby. What's wrong with me? Why am I not grateful? Because it's hard and you're tired. So I feel like acknowledging that this is a very tough transition is a huge part of getting people ready for that and preventing the depression. Motherhood, breastfeeding, bonding, none of those things necessarily come naturally. And it's okay not to like any of those things. The bonding too, a lot of people think their baby's gonna come out and they're instantly gonna fall in love with it. And a lot of times that is what happens, and a lot of times it's not what happens, and that's also totally normal. And so telling them that it's totally normal not to just fall in love with your baby the second you see them. There's a lot of motherhood-related negative thoughts that are very, very common. Guilt and shame, obviously. And then a lot of these are considered very socially unacceptable. You can't feel shame. You wanted that kid. You're a mom. You have to be on 24 hours a day. I'm supposed to love this. I wanted this kid. What is wrong with me that I'm not loving every freaking second of it? Which you say that out loud and it's ridiculous that we would ever put that expectation on ourselves. There's lots of things about motherhood that we are never told. And I don't really, there's just not enough time in the day to prepare everybody. So I don't know, we need a good handbook that everybody needs to read that's not what to expect when you're expecting. The thing is that nobody told you. That's what we need. But, all right, so then I was in the middle of fellowship, got pregnant with baby number 2. I really struggled with baby number 2. Things took a very dark turn. He was 100% planned. We got pregnant the second month of trying. And I very distinctly remember being not excited at all. And people would be like, oh, that's so exciting. Are you so excited? I'd be like, yeah, super pumped. And I, as a middle child, was very cognizant of the fact that all of the little things that I did with number 1, I had to do with number 2, so he couldn't hold it over my head, that I didn't have a 3D ultrasound of him. So I went to all the things, and I hated every minute of it. I was too busy. I didn't have time for this. And I went to multiple Dr. Mom groups that I was on Facebook and asked, am I depressed? What is wrong with me? I don't feel depressed, but why am I so indifferent? I felt a lot of worry about my first son. Am I still going to love him the same? Is he still going to love me? Is he going to be mad at me that I'm having another baby? Totally irrational. Why would he be mad at me? He's 2.5. He doesn't know any better, and giving him a playmate. So I really struggled with that. I also gained a lot of weight with that pregnancy. I had gestational diabetes. I was way too busy. I was in fellowship working about 100 hours a week. No time for sleep, no time for him, no time for myself. And I very distinctly remember being in the delivery room and the nurse said, all right, we're complete and ready to push. And in my head, I literally said, well, I guess there's no turning back now. That was literally what I thought, which is awful to think. I mean, it's not funny to me now, but I can look at it with a little more okay, I get what was going on in my brain. And then it came out and it was instant. I mean, instantly all those feelings went away. My son came in and he was in love with him too, and we were all fine. But it was just, I really struggled with, what is wrong with me? This is ridiculous. So I had a much better breastfeeding journey this time because I knew what I was getting into. I was already a parent, so I wasn't dealing with all the transitions, and I was able to focus on it. Still wasn't great, but it was much better. He got super chunky, and I was able to feed him all myself, which was a huge win because I couldn't do that the first time. But I was still so miserable. A lot of it at this point was related to weight and just my physical feeling. I felt like I was 80 years old. My back hurt, my knees hurt, everything hurt. I couldn't get down on the floor and play with them. So again, I'm feeling like a bad mom. I can't play with my kids. And it was a New Year's Eve. We were in the basement, and I was taking a video of one of them, and I watched it a couple days later. And he goes, Mama, play with me. And I said, oh, buddy, Mama's tired. And I was 35 years old. I shouldn't be too tired to play with my kid. I hadn't done, it was 10 in the morning. So that was my moment where okay, I needed to change something. This is not okay. So that was a big shift for me where I had to really start looking at what was going on in my life and start changing stuff. So lots of mom guilt, obviously. And mom guilt comes around a lot when we're trying to not just balance everything, we're trying to do everything really well. And if we can't do it well, then again, what is wrong with us? So we're trying to do our needs, their needs, our work needs, our house, our husband, going grocery shopping, everything, and we can't do it all. Public policy has a lot of a role in here. We don't get enough maternity leave. There's definitely not enough paternity leave. It's getting better, I will say, as someone who fills out all the FMLA forms. I get a lot of dad FMLA forms for 12 weeks now, which is awesome. I feel like I get more consistent dad ones than mom ones. So again, we're failing moms a lot. And there's just not enough support, postpartum, daycares, all these sorts of things. A lot of mom guilt can be very closely tied to economic well-being and education. Disliking pregnancy is a big one for a lot of people. They feel that guilt. Disliking or not knowing where you're going to deliver, who you're going to deliver with, who's going to deliver your baby, who's going to be your doctor. And then you get that guilt from other people, oh, you're going to do it there. You're going to do this there. People will say the weirdest stuff to you when you're pregnant. There's no filter. How are we going to feed our baby? Are we going to do breast, formula, pumping? Am I going to go back to work or not? And I might not like the stay-at-home life again. So lots of places to have maternal guilt. Maternal guilt and self-blame in general, when we kind of repeat it over and over and over, it leads to depression. The more depressed we are, the more our self-talk is dominated by negative words, and we put a much greater self-focus on all that guilt. This guilt, it's our fault that we're having this guilt. It's our fault that we're in this situation. It's our fault that our kid is having a temper tantrum today. So we put we're responsible for all this stuff. The more we do that, we get further depression, and the more depression we get, we go back to the maternal guilt. So it's just this awful cycle that just goes over and over and over and over. And so that's where we need to sort of break it. But here we are trying to do all the things, all of them, amazingly, and we feel like we should because it's all over TikTok and it's all over Instagram. All these women in their white houses with white carpet and couches, and their kids are all dressed in white, and they're cooking like strawberry something or other. And no, it's not how it is. How can we do it all? Well, you can't. I mean, it's impossible. I mean, and we need to come to this realization that nobody is doing this well. They might put one thing on social media, but nobody is doing everything well. We have to learn how to balance it. That's the key. And balancing it means that some stuff is going to be absolutely half-assed, and some of it's going to be done well. The stuff that needs to be done well will be done well. We have to learn how to prioritize. And one of my favorite quotes is that sometimes good enough is good enough. I use this in clinic. I was burning out 2 years ago. Notes, our notes was a big thing. And I remember I had a patient who went and saw one of my partners for a UTI. And I would have written this, oh, this patient comes in and they had 7 days of this and they weren't doing this. His note said, 1 week dysuria, no fever. And then in the physical exam, no tenderness. And then in the assessment plan, Bactrim, 7 days. And I was angry reading it because I was like, oh, I would have written so much more things, but did I get everything I needed out of that note? I sure did, because good enough is good enough for that patient. And so that's what we have to do at home, you know, like, is our house need to be pristine and clean? No. Is it not stinky and disgusting? Yeah, that's good enough. So coming up with that quote, I tell myself that all the time. Sometimes good enough is good enough. So, and it doesn't have to be your best. Some stuff does, but not everything. Most stuff does not. So we hit COVID. COVID was a really hard time in healthcare, obviously, because there was so much unknown and we didn't know what was going on. How do I keep my patients safe? I was one of the few people that actually didn't slow down because I was seeing pregnant women and babies. And everybody else kind of slowed down, but no one else, they weren't telling us how we were, you know, going to get paid. And so after a little bit, people were like, well, we're just going to keep seeing people. And so I'm trying to bring pregnant women and newborns into my office, and other people are bringing COVID patients into the office. So just that struggle of how do I keep myself healthy? How do I keep my patients healthy? How do I keep my children healthy? I did distance. I very much took a sacrifice, and we didn't have a bubble. Our bubble was the 4 of us. We didn't hang out with friends. We would have friends come and they would stand 6 feet apart. We would do some distance walks sometimes where we would walk on opposite sides of the street for a little while. Lots of Zoom hangouts with friends from all over the country, and those were fun. I got a lot of solace from like online groups. And I feel like social media has a lot of power in good and bad, and this was a place where I felt like it really helped keep people's mental health because you were able to connect with people online. Ultimately, I did get COVID and ended up in the hospital for a week and was really, really sick. And so that led to a lot of anxiety. This is where anxiety became a big part of my life. It never had been before, but anxiety was a new fun thing. So in the world of online groups, I'm sure we've all experienced toxic moms. And it's really hard to piece out what groups are good and bad and how you kind of navigate that. But these are just some of the things that I have seen people get attacked, like absolutely destroyed on social media for. Like if you're gonna have a vaginal delivery or a cesarean. Well, if you've had 3 cesareans before, I feel like that seems pretty clear if someone says they want another one. And they would fight them to the death on these things. It was insane. Postpartum support, there was literally this woman who was like, seriously, you need someone to come and help with your 2 other children and your baby? You can't do that by yourself? I was like, you gotta be kidding me. So, I mean, it was insane. I had put a question up once on one of my doctor groups, just, oh, my son was told, you know, he's young for his age, or in his grade rather, and so when we were going into kindergarten, he didn't test into kindergarten. They were like, yeah, you would actually like to hold him back. And so I posted it, and hundreds of, if it's a boy, do it. Just do it. Hold him back. You'll never regret it. And I was kind of like, okay, let's do it. And there was this one woman who goes, well, someone's kid has to fail. I was like, really? Like, you would let your kid be the one to fail if you had the option to hold them back? Like, what an awful thing to say to people. We talk to people over social media sometimes, and it's just appalling. And I think this is where we almost subconsciously get this idea that it's okay to talk to ourselves like that. But yeah, all these different things, these are all like examples. So looking at some statistics, 23% of moms say that social media has negatively impacted them. I would assume it would be way higher than that. I recently got kicked off of Facebook permanently for a really funny reason. Actually, I was in an addiction doctor group, and someone wrote, is anyone seeing heroin? Because we're actually starting to see heroin again in New Mexico. And I put, oh my God, I miss heroin because it's so much easier to get people off than fentanyl. Gone. Can't fight it, I'm gone, because I said I miss heroin. So But my mental health has been so much better getting off of Facebook. I didn't realize I was into this doom scrolly, catastrophizing sort of a situation until I was out of it. But 49% of moms said that they're not going to post or comment because they're afraid they're going to get attacked. Again, I would assume that would be higher. And it might be, we're just not asking all the right people. 81% of moms, they're using Facebook as opposed to like 61% of the general population. Facebook seems to be the bigger place for moms to kind of go, whereas a lot of other people are at like Blue Sky, YouTube, Instagram, stuff like that. And then 35% of moms say that this is their connection to the outside world. I absolutely tell my patients, usually I refer them to Mission Mother, I'm like, have you heard of this site? You need to get onto it. But I'm like, if they don't have transportation, if they don't know anybody in town, like this is how you can connect with people. I didn't find my people until I found a Facebook group of doctor, mom, Peloton riders, which is like a weirdly specific group, but these were my people. They understood all the same things I was trying to go through. Yeah, it was awesome finding that group, and I still, to this day, even though I'm off now, I talk to them daily. These are like some of my best friends. So social media can be an amazing place to connect people. 79% of parents get medical advice. I can't be in regular groups because of this. Like I can only be in the doctor groups because I can't not comment. Please turn your kid back around. They still need to be rear facing. Oh my God, don't do that. I can't do it. And the advice, and they're not getting advice from doctors. They're getting advice from mom groups, which some of it's good advice and some of it's terrible. But to combat that, there's a lot of doctors who are now getting platforms on Instagram and YouTube and TikTok and all these places. And there's phenomenal doctors, phenomenal advice to have out there. The one guy with 1 million faces, he's like huge in the doctor community. He's Dr. Glaucomflecken. He's an ophthalmologist who plays all the different roles. And he's hilarious and very anti-insurance companies and stuff. It's hilarious, but lots of different places to get the information. And this is how we're trying to combat a lot of the misinformation and educate our patients. And it's good. It is for good. So, all right. So we're mid-COVID. We got the vaccine. And I was so excited to get it because my father-in-law was actually one of the developers. I got his vaccine and I cried a little bit because it was nice to feel like I was going to get some protection. I turned 40 and did a nice little 40 photo shoot, and I felt so gross. I hated that photo shoot so much, and it was so fun, but I kind of hated it. Again, it was all about my personal appearance, and I just wasn't comfortable in my body. Really still not liking who I was, so lots of negative self-talk, but I do feel like it was shortly after I turned 40 that I started realizing, you know what, like, I don't care what people think anymore. I don't care if other people don't like me. I like me, and my friends like me, and my family likes me. I don't need everybody to like me. And that was the turn. It was about a month or two after I turned 40, after I went on this trip with the little photo shoot. So now, in the world of mothering with substance use disorder, I've just talked a lot about how terrible it is to mother, just period. Now we're going to throw in like a massive mental health crisis with it. So as we can imagine, this can make things pretty terrible for a lot of women. And then we throw in there that like there's a lot of states out there that criminalize this. So someone doesn't know she's pregnant, she shows up in the ER with abdominal pain, they do a positive pregnancy test, okay, you're pregnant. And even if she gets herself into recovery, the fact that she had a positive like urine drug screen, they can charge them with fetal abuse. There's 23 states that allow full prosecution of women, and there's 2 or 3 states that they're allowed to force women to go into recovery, which it's good to get people into recovery, but if you can't force people into recovery, they need to be ready. And if you're not ready, you're just going to put a bad taste in their mouth and turn them away from wanting to do it when they are ready. So the criminalization thing is really tricky, and Indiana is not one of these states. It's actually we've got some good laws that protect women. So. Motherhood and grandmotherhood is actually a great motivator for recovery. I've seen a lot of women who, they either have a kid in the system or they've lost their kid completely, and they get a positive pregnancy test, and this is it. I'm going to do this one different. We're gonna fix me, and they do amazing. There's definitely a motivation. The relapse rates postpartum is about 40%. So I always kind of tell them our goal for the pregnancy is to build your little framework. We're going to get counselors. We're going to get support people. We're going to get you housing and insurance and a phone and a job, all these things that you need. And the big trouble is that for a lot of women, this is also a barrier, right? So you're a mom and you want to get yourself into recovery. How do you go to a program when you have a kid? Who do you call? DCS? They're all terrified of calling DCS. There are some respite programs that people can sign up for that are through some of the churches where you leave your kid with a family that's been vetted and the courts are not involved, and so they can go to recovery, and then when they're out, they can come back. But this is something that definitely keeps people from going into recovery, which is sad. And I get it, but it is sad. Now, child separation is one of the biggest motivators for relapse. I've had patients tell me, multiple patients, if they're going to take them away anyway, I might as well not feel it. I mean, I get that. That's your coping mechanism. I get that. And so that one's hard. I feel like we have a lot of work to do in terms of how we structure this, and we're definitely making progress. I feel like I've seen a lot more of these safety monitor things where instead of the mom not being allowed to live with the baby, the mom can live with the baby, but someone else is kind of in charge, and I love that for them, because what's a bigger motivator than that kid sitting right in front of you every day? So it's a great way of fostering it. We're making good progress, but we still have a lot of places to go. I feel like one thing we definitely need are more like recovery programs where moms can go with their kids. There's just not enough resources for that. It's really, really hard. So it takes a lot of funding, which is being cut at an accelerated pace right now. So I don't know what the future will look like in that, but I think that would be a huge place for us to get more people into recovery. And then we have all the untreated mental health conditions. You know, we can get them a negative drug screen and get them a job, but if we're not fixing why they're there in the first place, they're just going to go right back. And there's definitely not enough mental health support in Fort Wayne or anywhere in the country, honestly. So, and then there's this fear of children going into the system. So a lot of people, because of that, they won't try and get help because they fear that if they try and get help, they're going to get penalized, the kids will be taken away, and that's the end of it. So there are people that just like try and go to another state and have a baby. Oh yeah, I got prenatal care at this place and I need to go at 24 hours because it's my aunt's funeral. And it's really sad that that's what's keeping them from getting into recovery. So just that fear for asking for help and that you're going to be penalized. Defeating language, a lot of people use a lot of defeating language. So, you know, how can I use drugs when I'm pregnant? What is wrong with me? What kind of a mom am I? I'm so stupid. Like, this is a disease. This is not something that you have control over 24 hours a day. I'm never going to get clean. I'm going to be like this forever. I'm not worthy of a better life. No one's going to love me. Why would anybody love me? My baby's not going to love me. You know, this treatment's not going to work. I've failed 10 times. Why would it work this time? Well, because it's going to work at some point and when you're ready. Just like battle, just like war. You can't go into a war just ready to fail. If you go in with confidence and you go in with some optimism that maybe this time will be different, that's how you go in and fight these things. So I always tell people, you got to pump yourself up before you go into any of these things, and you have to try and believe that this time can be different. And if it's not worked before, why didn't it work before? How can we fix it this time? How can we set you up for more success? So a lot of people will feel like they're worthless. Again, we lead into this depression. This depression can lead into this hopelessness. Hopelessness makes people want to escape, and so then they can relapse. And once you relapse, oh my gosh, you're worthless again. So it's, again, just these cycles of stuff that people can get stuck in. All right, we're post-COVID, and I was able to turn things around and start exercising and taking care of myself and getting good sleep, and I feel like this is the time where I look at I was looking through all these pictures over the past week trying to find pictures for this, and there was definitely some early ones that brought me to tears just looking at, I could see how miserable I was, and it really was sad just remembering the stuff that I would tell myself. And this was the point where I could see that I was happy. There's this picture. I felt so happy in that picture. Like I really did feel happy. That was one of the first times I was really, really, truly in a great place, and I felt good, and I felt like I had good, positive self-talk. There's obviously going to be negative self-talk everywhere, but I had a lot of positive self-talk at this point. And language, our language matters, how we talk to people, and so one of the things we really want to make sure that we're cognizant of with patients is that how we talk to them, the words we use. People don't see themselves as patients. They don't see themselves as sick. They see themselves as I have a moral failing. I'm a bad person. There's something wrong with me. There's a lot of shame, embarrassment, ostracism. And so it's really important that when we talk to them, we focus on them and not their disease. So, you know, one of the big things is we're using people-centered language. We're not calling them an addict. We're not calling them an alcoholic the same way we wouldn't want to call someone a diabetic. That is not who they are. It does not define who they are. It's a person with substance use disorder, a person with a history of addiction. They're not their disease, and we want to make sure that we're acknowledging their identity and that we're giving them some dignity and some self-worth and separating them from that. It's just a part of who they are, but it is not who they are. The stigmatizing language that we use, it can perpetuate a lot of negative stereotypes. My least favorite one, and I hate this so much because I hear this all the time from people who mean really, really well, and you can see the mom's brain cycling when she hears that baby was born addicted. Addiction implies dependence and behavior. No babies in the world are born addicted. They're born dependent. And so that sort of stuff, I mean, as soon as we start getting into the world of withdrawal, the rates of depression are incredibly high. So I try and talk to them a lot about, like, you did everything you had to do to have a healthy pregnancy. I would never have recommended coming off of it. If you said you really wanted to, I would support you doing whatever you wanted to do, but I'm not going to be the one to tell you to come off of it. So trying to make sure that they're realizing that what they did was hard and they were putting their baby first by staying on it, honestly. Using the stigmatizing language, it hinders communication and it puts a barrier into treatment so people won't come and access care. And then there was a good study that looked at using punitive language. So as an example, like a 23-year-old heroin addict comes in again to our ER as a frequent flyer here, continually requesting pain meds. Pain seeking would actually be a good word. Rather than being like a 23-year-old woman with a history of pain that is difficult to control, comes in today with uncontrolled pain. So when they use the other language, they're less likely to give them pain medicine, they're less likely to work them up, they're more likely to send them out without any sort of a diagnosis. And this is where people don't get the care that they need. It adversely affects the quality of care. It loses their trust in the medical system. I used to have an office on Lake right behind Vandalia Hospital. And I had a patient who was seeing me for pregnancy, and I got sent a note that she had called, and so I opened up the Epic portal. And she had seen an ER doctor, and literally word for word it said, she said she's seeing an OB-GYN named Sarah Turner. There's no Sarah Turner in Fort Wayne, so she's clearly lying. So I Googled myself, and I was the top 3 hits. So like they didn't even take the time to Google me. I'm right behind your ER, you know. So it's just, this is the sort of stuff that makes them not, and I get it, I wouldn't trust us either. And so it takes us a long time to build that rapport. I feel like I don't get a lot of my patients to trust me till they walk out the door of the hospital with their baby. They think I'm going to take their baby up until that point for the most part. And I get it, I don't blame them. I would probably think that way too. I often don't know their story until they're discharged from the hospital and they've told the nurses because they won't ever tell me everything. And that's fine. As long as you're telling someone and you're getting the care that you need, you can keep secrets from me. Eventually, they usually tell me the stuff, so. And then the one thing I also see is I see this becoming some sort of a self-fulfilling prophecy. Well, you know, of course I relapsed, I'm an addict. This is gonna happen, it's who I am. Nope, it's not who you are, it's a chronic disease, and just like all other chronic diseases, we get relapses. But that doesn't mean you're right back from where you are, it doesn't erase all the progress that you've made and all the positive changes that you've done. It's just a relapse, so let's reframe. So these are all the sort of stigmatizing languages that we shouldn't use on the left and then should use. So most of them make sense, it's just that first person sort of stuff. And then a couple other detox, don't say detox, you say withdrawal management, don't say clean and dirty. We say, you know, positive or negative for substances, stuff like that, so. Another thing to be aware of is nonverbal cues. So we want to make sure that we're being really aware of these because a lot of patients are very, very sensitive to this. So sometimes we'll explain something and they hear something totally different, or they're projecting their feelings, they're projecting their guilt or whatever. And so I always try and make sure that since they're taking offense, I try and explain. If I can see that they're taking offense, I'll like, can I explain it any further? I always try to sit. I want to use my body language to not speak over them, and if I'm standing next to their bed, talk down to them. Using the tone of voice, making sure we're making eye contact with them. And then also, a lot of these patients have a history of abuse, so I never touch them without asking first. So sometimes they'll be sobbing, and I'm like, can I give you do you want a hug? Can I give you a hug? If you don't want it, it's okay, but just touching them without asking, even though that might be your first instinct and it's coming from a great place, you just have to be aware that a lot of them are very not comfortable with touch. So baby number 3, I was a surrogate for some friends. My husband was done. I wasn't as done, but I was eventually. So I was a surrogate for some friends, and I love that picture. So the woman in the yellow thing was a Peloton instructor, and she posted that thing in our Peloton Mom doctor group. And I immediately was like, well, I'm going to recreate that. And that was the biggest I've ever been in my life, but I had full appreciation for what my body was doing. So I love that I was totally comfortable posting that photo online because it grew a baby for another family and created a family for them, and I was totally cool with it. So I love that I was comfortable with my body enough right there. And it was a terrible pregnancy. I hate pregnancy so much, but beautiful baby, awesome experience. So it just sort of reinforced that self-talk, and it made me feel like my body was worthy. Now, how do we fix this? How do we fix the language? How do we fix how we talk about ourselves and to other people? The biggest thing is being kind. It seems very simple, but we are not kind to ourselves. We talk to ourselves the way we wouldn't talk to people we hate. Like some of the stuff that I've said to myself in the past, I can't imagine saying out loud to anybody ever. And so focusing on what we've accomplished rather than what we have not yet accomplished. We have these lists, 400 points long of things that we have to get done. No one's ever going to get them all done. Focus on what you can get done. Small wins are huge wins. I have to tell people that all the time in the world of substance use. You came to my office and you asked for help, and that is hugely hard to admit that there's a problem and put yourself at risk, and especially if they have other kids. You really put yourself out there because what if I was a total mean person? So I feel like I got to kind of reframe that for them. And, in their mind, they should never have been doing anything before, so they're getting themselves to neutral rather than getting themselves to an amazing place. But trying to reinforce that you're proud of them, I feel like they don't hear that very often. So telling them that you're proud of them in just the littlest things, they're really huge accomplishments. We need better public policy. We need more maternity leave, more paternity leave, more resources for daycares and insurances, and lots more resources for mental health and substance use disorder, for sure. I like this one. You're very good at being depressed. So, focusing on that. And so we don't want to stop those negative self-thoughts because the negative self-talk is actually what keeps us out of danger. We need that to kind of get our boundaries. We just want to make sure it's not dominating, and we want to make sure that we're responding to it in an appropriate way. So there's lots of ways that we can kind of like respond to this negative self-talk. We can use the positive self-talk and flip the thing. We can personify our inner critic, so give it a name. Call him like Steve. And so it's not you, that negative person is not you, it's somebody else, it's your subconscious, so separate that. Use some mindfulness, okay, it's healthy and normal to have these thoughts. There's nothing wrong with me. I'm not gonna overreact to this. I'm gonna counter it with logic. Okay, logically, the world is not gonna collapse today if I don't clean the house. So you have to kind of be logical. And then making sure that we're replacing as many of the negative thoughts over time with positive thoughts. And the more you do that, statistically, you actually completely flip the thing. The more negative you think, the more negative thoughts you'll have, and vice versa. So. It's so important that we learn how to love ourselves. We cannot be loved by anybody else unless we learn how to be loved. And we have to love ourselves first because we don't know how to teach other people to love us. And we are with ourselves forever. We are our longest relationship. So learning how to love ourselves and appreciate all the little flaws because those are part of who we are. It's not a bad thing. And that's a hard realization to come to, and I feel like it takes a lot of time to come with acceptance. But it's an awesome place to be when you can get there some of the time. So yeah, I feel like I have gotten to a place where I'm good at the self-talk, and it took a long, long time. I feel comfortable with my body, even though I know it's not perfect, but every stretch mark was a baby kick, and every wrinkle was a smile at some point, so I feel like I got peace with that, and I definitely feel like I can be kinder to myself in the mirror. I don't love looking at myself in the mirror sometimes, but that's okay. That's normal and healthy, so. That is all I have. Any questions? All right. Thank you guys so much.
All right. So I want to just remind folks to take the AHEC survey if you haven't done it yet. I might have a QR code for you out there. This conference, again, wouldn't be possible without our sponsors. So thank you to the University of St. Francis. Thank you to Fort Wayne Metals, Starak Family Foundation, and CareSource for making this happen. Truly thank you for everyone who stayed for 2 days, or whether it was a day or yesterday, or whoever. I'm just so honored to have you here and participating in this. Next year, it's the same time. First week of May, first Wednesday and Thursday, so put it in your calendars. We'll have our presenters slides for you. I'll send it in an email in a few days, maybe next week. We'll have pictures and other things from the conference as well, so for you can reference. Thank you so much from the bottom of my heart, and I hope you guys have a wonderful day and take care of yourselves.
Have you ever in your entire life seen anything so beautiful?
you.